With great pleasure that I introduce our first speaker, Dr. Peter O'Dell. Peter is a consultant in anaesthesia, perioperative medicine at University College London. His specialist interests lie in obstetrics, orthopaedics, regional anaesthesia and surgical intensive care. He has completed a postgraduate master's in perioperative medicine and is preparing a PhD on accidental awareness during general anaesthesia. And it's about his DREAMY trial that we're going to hear today. So Peter has led multiple NIHR portfolio studies. He's a Cochrane author, he's lectured internationally, and is a regular peer reviewer for journals. Peter's research activities have also been united by an ambition to increase participation and access to research by anaesthetic doctors in training, including development of a pan-London anaesthetic trainee research network. Out of work, Peter is a keen basketball player, and when not hustling on South London courts, can be found figuring out parenthood with his wife and young children. So I'll pass you over to Peter.
Morning, Kay, and morning, everyone else. Thank you for the invitation to speak. It's nice to be back in Yorkshire, even if it is only virtually. I actually did my F1 and 2 years in Leeds, so yes, it's good to be back. So I've got no conflicts of interest to declare, although technically I am a Lancastrian, so apologies to all you hardcore Yorkshire folk, and I hope you won't hold that too much against me. I'm going to be discussing the background and findings of our study of accidental awareness during general anaesthesia, or ARGA as I'm going to call it, which was the largest cohort study of OBS GAs ever conducted. So it's divided into two parts. The first is a descriptive study of OBS GA activity, airway complications, patient characteristics, and the work patterns in obstetric GAs. And the second is an analytic study of the incidence, experience, and implications of ARGA in maternity patients. And both results papers have recently been published in Anaesthesia, with a protocol published in YSOA, and a couple of editorials sat alongside them as well. And there's a lot of challenges, as we know, with obstetric GAs. There's a lot of challenges about thinking about obstetric GAs and about studying them as well. And I think we all understand that whilst hard outcomes like mortality have declined dramatically when associated with obstetric GAs over the past decades, there's still significant risks associated with GAs for maternity patients, and they're stressful for anaesthetists, they're unpleasant, undesirable, and often unexpected for patients. And what I think is interesting is how resistant obstetric practice, particularly the obstetric RSI, has been to change over the past decades. And the obstetric theatre is pretty much the last bastion of the classical RSI thio-sucks technique. And that's despite recognitions of this practice as being high risk. And so part of the role of the study really was to help unravel that dilemma and to pinpoint a refreshed rationale for change. And I think awareness is a really interesting risk, actually. It's very fundamental to what we do as anaesthetists, which is to safely take a patient from a conscious to unconscious state, then back again, and make that process of surgery safe and tolerable. And ARGA is one of the very few perioperative complications where we as anaesthetists have sole and undivided responsibility for it. And interesting, obstetric patients are something of a perfect storm with a unique confluence of major risk factors for awareness. They almost all have neuromuscular blockade, they're young, female, a lot of emergency surgery, out of hours surgery, and difficult airway management and obesity. And there may even be additional pregnancy-specific factors that influence anaesthetic sensitivity and resistance, which are quite poorly defined as of yet, because it's very difficult to do research in GAs for pregnant women. And so no previous study has actually attempted to record what it means to suffer from awareness during the time of childbirth. And in fact, we have to rely on a very small handful of longitudinal studies for understanding what the psychological impacts of awareness can be after the event. And there's no getting away from the fact that obstetric GAs are something of an intractable requirement as well. They're always going to be required, often at short notice, and 24 hours a day, 7 days a week. And there's very few surveys over the past 10 years, but some of them have shown that practice is changing. But to me, I think the big question is how much has practice changed and what can we still do better? And I wanted to show you this slide, even though it's slightly old data, it's actually local data. So this is from Gordon Lyons in Leeds. And what it shows is the number of obstetric GAs decreasing with successive years. And also the number of trainees increasing, meaning that the average GA per trainee declines to something like 1 a year by the mid-2000s. And of course, whilst there's ways of overcoming that deficit of hands-on experience with simulation training, we have to acknowledge that there's a dramatic reduction in the experience of trainees with handling obstetric GAs. And there's also challenges in any study that measures awareness. And that's because awareness is a very complex outcome measure to record. It's not something that you can do a test with a binary outcome for, or a test with a known precision. What it relies upon is honest reporting. And for that, you need high quality, rich, consistent data. And ideally, you need to triangulate that data from multiple different sources so that you can get a fuller picture of what is reported and confirm or refute any specific claims made by patients. And of course, it's qualitative data, which has got impacts for how you analyse and report it. And not only that, but it can also be subjectively interpreted as well. And as I've already pointed out, obstetric GAs are rare, and so awareness is rare. So you're trying to find something that's rare in a rare event, which has got implications for how you design the scale of the study too. And if we define awareness as an unintended return of consciousness, then of course measuring what we mean by consciousness is quite complex as well. Even in simple abstract terms of phenomenology, just measuring what it means to feel like to eat a bar of chocolate or to experience the color purple is very complex. And to me, I think part of what I find fascinating about awareness research is that firstly, it represents a proxy into understanding consciousness. But secondly, it also helps me to remind the wonder of what we do each day and what we make seem ordinary. And that's disassembling the functional architecture of a patient's mind and then putting it back together again. And of course, we use colloquial terms like going to sleep, but we all know that a GA is not sleep. And there are completely different mechanisms and completely different effects on brain behavior. And so the type of awareness that we measured in this study was explicit recall, or awareness of explicit recall. And I think that's probably the easiest to justify as being the most clinically relevant form, but it's not the only form of awareness. And so there's two other forms of awareness that we can talk about. The first is as identified by isolated forearm testing, and the second is called implicit learning during GA. So isolated forearm testing is probably best popularized by another Yorkshire anaesthetist, Ian Russell, who subsequently retired from Hull. But the technique essentially involves giving an induction agent with a blood pressure cuff inflated above systolic pressure, usually on the dominant arm, and then that cuff is inflated before a muscle relaxant is administered. So what you have is a vascularly isolated forearm with the whole body subject to paralysis apart from that arm. And then in the testing, patients are given verbal commands, and that command normally takes the form of saying the patient's name and then asking them to squeeze their dominant hand once or twice. And even in the most recent, best conducted isolated forearm studies, then around 5% of patients, rather spookily, respond to these commands. And there are some peculiarities around isolated forearm study, which make them quite difficult, I think, to understand exactly what it means. And the first is that patients move to command when one arm is paralyzed, albeit only a small proportion, but almost never move to command when we speak to our patients when they're not paralyzed. And there's no obvious control study been done, which is to do an isolated forearm test with rocuronium, find a positive response, and then reverse the neuromuscular blockade with sugammadex and test again. But it does appear that there is something inherent about a drug that has no central nervous system activity, i.e. muscle relaxants, that seems to enable isolated forearm responses to occur. And on the surface of it, isolated forearm seems to involve very complex signal processing, because of course, to understand that verbal command, you've got to understand the semantics and syntax of a verbal command. You've got to recognize that that command is for you as an individual rather than for anyone else. And then you've got to decide to action a simple motor response. Unfortunately, I don't think that any of the neurobiological models that we have for interpreting how or why ISF responses occur are particularly satisfying. And there are some theoretical problems with understanding, therefore, what ISF testing means, other than that your depth of anesthesia is probably insufficient. There's also no longitudinal studies to suggest whether ISF responses are actually important. And certainly almost none of the patients that have been recorded as responding in prior studies remember the experience immediately after surgery. The second type of awareness during anesthesia can be tested for is with an implicit memory, and that's called percept or concept priming. And essentially it involves identifying behavioral changes after anesthesia. And usually these tests involve playing audio recordings during a general anesthetic to a patient and linking them with post-op behavioral changes. And typically those behavioral changes are things like word stem completion tests. So if you present the letters TRA to a patient who's had the word traffic said to them repeatedly during the anesthetic, then the tendency for them to associate that with the word traffic rather than tractor or something else would be an indication of implicit learning. There's also some more advanced testing called concept priming, which involves playing stories to patients during general anesthesia and then giving free choice word association afterwards. And one example of that is playing the story Robinson Crusoe to patients and then asking them to free word associate with Friday afterwards. And these studies involve some logical leaps, some mixed evidence of responses, and probably some light anesthesia. But there is certainly some evidence that you can influence behavior postoperatively by intraoperative auditory sensory stimulation, which is in itself an intriguing prospect. So we deliberately didn't study ISF or implicit learning. Instead, we went for what I think is the hard currency, and that's ARGO of explicit recall. What isn't necessarily intuitive is there's actually several barriers that prevent the brain from producing reliable memories of intraoperative events, even if there is a very marked mismatch between anesthetic supply and brain requirements to obliterate consciousness. So three things essentially have to happen together in order to generate an awareness experience with memory of it afterwards. And the first, of course, is that you have to have a deficiency in the delivery of an effective dose of anesthetic to the brain. And there's lots of reasons why that can happen. TIVA disconnections or genetic resistance to anesthetic drugs or a drug error. And then that deficiency has to result in a return of consciousness. And we often think of consciousness as being a bit like a light switch that we can flick off and on in a binary manner. But of course, it's not quite like that. And practically, we often use a lack of responsiveness as a surrogate for lack of consciousness. And indeed, that's the assumption that MAC measurements are based on. But of course, that's not quite true either. We all know that consciousness is graduated. And even once we pass that threshold for lack of responsiveness, then there's actually several different brain states of unconsciousness that involve different levels of information processing. And what's far more likely than having a light switch for consciousness is that actually we have a dimmer switch that controls a whole bank of different lights. And each of those lights represent different components of that complex neurobiological process that contributes toward consciousness. And probably each of those different factors have got different dose response curves that influence how and when they switch off too. So what we do when we administer a general anesthetic is that we suppress information processing in different parts of the brains at different dose responses. We suppress attention fields and noxious stimulation arousal systems. We suppress memory systems and autonomic responses and somatic responses. So there's a huge array of effects that occur, and it would certainly be an oversimplification to assume that that occurs in a simple binary manner. And there's actually plenty of evidence that auditory sensory processing requires greater anesthetic dosing than other sensory processes, for example. And then finally, memory. So memory is disrupted not just by the pharmacology of a GA, but by the process and temporal sequence of a GA as well. So remember that retrieving a memory isn't like replaying an event in your mind, it's more like reconstructing it. So memory relies on familiar cues, and we're more likely to accurately construct a memory if the situation is familiar to us. And events that are distressing or stressful or unfamiliar often take on very different patterns called trauma memory. And those often allow the memory to focus on a central event, but forget a lot of the peripheral details. And memories are susceptible to being overwritten too, of course. So what this means is that if a patient has an awareness experience during an operation and recalls the sensation of an endotracheal tube, then they have a very similar experience during emergence and extubation, and that later memory may well overwrite the first. A bit like remembering the last name of the person that you met at a party and forgetting the names of those that you'd met earlier. And of course, the amnesic drugs that we use for most GAs, or the hypnotic drugs that we use for most GAs, have got amnesic effects at lower doses than their hypnotic effects. So what this means is that memory function is a really important barrier to measuring awareness, and that your measurement technique for awareness needs to be sensitive to that, but also sensitive to the fact that you can bias memories through interviews too. So the very act of trying to identify awareness with explicit memory involves an interactional research instrument, namely the patient interview. So the bottom line is that it's actually very likely that patients are aware far more frequently than we can detect via explicit memories. And so this study is probably actually an underestimate of what you might consider the true incidence of awareness. And actually, it was the simplicity of the NAT5 methodology that I found quite appealing. So there was no interview to detect awareness. It relied purely upon spontaneous reports by patients. And of course, NAT5 was the largest study of awareness ever conducted. You could imagine that theoretically it involved around 3 million patients, although that assumes that all patients were given the same opportunity to report as each other, which almost certainly isn't the case. So NAT5 collected unique spontaneous reports of awareness during a 1-year period of data capture in hospitals across the UK and Ireland. There was no screening and there was no follow-up. But for me, what really set the study apart was an incredibly thorough adjudication process. It went into detail grading the reports and making sense of the context and identifying learning points from each of the cases. And one of the headline findings was a huge overrepresentation of obstetric patients. So obstetric patients represented about 0.8% of all the GAs in the activity survey, but around 10% of all the awareness reports. And actually that incidence is probably an underestimate as well, because many patients may have experienced awareness but not had the opportunity or motivation to report it to an anaesthetist during the year of data capture. So what NAT5 clearly highlighted was that obstetrics is a dramatically high risk for awareness compared with any other surgical specialty. But I think there are question marks around the exact incidence that is reported or estimated. So what we did was design an appropriately powered, large-scale study to investigate the epidemiology of awareness, meaning the incidence, experience, and its implications. And that involves screening patients rather than relying on spontaneous reports alone. And this was very much a grassroots study, so involved over 700 investigators across England in over 70 hospitals and 3,115 obstetric GAs. And a lot of the study design phase was very much focused on learning how we can take the next best logical step in terms of collecting high quality data about awareness on a large scale. And we made a lot of refinements, which were largely just standing on the shoulders of giants, particularly NAT5, to methodology for studying awareness. And that went as far as even modeling the effects of different number of panelists on adjudication panels and looking at behavioral factors for how those adjudication decisions are made. So a lot of obsessive detail about the methodology for detecting awareness. And we broke down that data capture into 4 different phases. So detection, So that was screening using 3 repetitions of a Bryce questionnaire, which is 5 simple questions about what patients remember about their intraoperative experience. And that was done over a 30-day period. We then did verification processes where we did secondary interviews, detailed interrogation of anaesthetic records, and looked at whether other staff could confirm or refute any specific claims made by patients. We then had adjudication panels that were all done according to predefined methodology, and likewise classification structures that were all pre-declared. And we recruited women having any obstetric indication surgery from 24 weeks on to 48 hours postpartum, over 80% of which were cesarean sections. But we didn't include non-obstetric surgery happening during pregnancy, so women who had an incidental appendectomy during pregnancy, for example. And so the first results paper answered a lot of questions around what we do in terms of current anaesthetic practice. And for me, one of the standout findings was this dramatic reduction in the use of thiopentone in the last 5 years. If you look at the NAP5 survey, then around 97% of obstetric GAs were involved thiopentone administration. And a similar survey around a similar time indicated that obstetric anaesthetists preferred to give thio for 93% of anaesthetics. In contrast, we found that just over half of anaesthetics involved thio in the study, and that contrasts dramatically with very little use in non-obstetric practice. So that's 2.9% in NAP5 and 1.7% in the NAP6 activity surveys. So why are we continuing to make a special case out of obstetric RSI rather than align our practice with non-obstetric RSI technique? And I'll set out my stall. I don't think thio is a bad drug, but I think there's very strong evidence that it's been used badly in obstetrics recently. And that covers overdosing being associated with maternal death in the recent Embrace reports. It includes underdosing being associated with NAP5 awareness in NAP5. And this leads to something of a self-fulfilling prophecy, really, where we have a decreased experience of trainees with the drug, which then in turn decreases clinical use of the drug. And of course, infrequent use of any drug potentiates additional problems, not in the least things like drug administration errors. And despite predominant action on exactly the same GABA-A receptors, propofol's got dramatically different effects on cerebral blood flow. And what it preferentially affects is your prefrontal cortex, which is where the working memory resides. And so if your objective is simply to ensure that patients don't remember awareness, then propofol is probably a better drug for it. But even if you want to go further beyond that, then as far as unconsciousness is concerned, then there's actually very recent evidence from obstetric patients that propofol at a dose of 2 milligrams per kilo tends to produce deeper anesthesia than thiopentone at 5 milligrams per kilo. And there's 13 small randomized trials comparing maternal outcomes with propofol and thio, all of which have essentially shown equivalence in terms of maternal hemodynamic safety and neonatal outcomes. And then there's one other final nail in the coffin for thio, which is that, of course, it fails to obtund laryngeal reflexes in the event of requiring a supraglottic airway for failed intubation. And so the question is, should thio be abandoned in obstetric practice, or should we be investing greater time and effort in training to learn how to use the drug more effectively? My 2 cents, I think that use of an increasingly unfamiliar drug during a technically challenging procedure, despite the drug being repeatedly associated with adverse outcomes for maternity patients, is a pretty challenging argument to defend. So this is patterns of thio and propofol use across the country from the DREAMY study. So the size of each of those circles represents a number of patients recruited in that area. And about a third of all the patients were recruited in London, which reflects a greater density of participating hospitals rather than that we do more GAs per capita in London. And of course, there's some marked geographic divides that you can see on that map. Some regions are more progressive, some are more traditionalist, I think is the polite way to phrase it. So North London and Oxford seem to be the biggest fans of FIO, whereas Wessex, East Anglia, and the few hospitals that we did involve in Yorkshire seem to favour propofol far more strongly. Just under half of patients received opioids, but for C-section surgery alone, it was more like around a third. Sux use was 85%, ROC 11%, and sevoflurane was used as the maintenance agent for the vast majority of anaesthetics, with around half using nitrous oxide as a co-agent too. And there were more GAs during the day than during the night, but once you remove the elective patients from that category, which were of course only during the day shift, then there was actually a slightly higher proportion of Cat 1 to 2 sections overnight. So there were more emergency GAs overnight than during the day. And emergencies were predominantly dealt with by non-consultant grade anaesthetists. So in fact, the greater the urgency of surgery, the less likely that a consultant is to be involved. And overall, about 54% of surgery was classed as category 1 or emergency. When it comes to airway management, 1 in 19 patients required 2 or more intubation attempts, or were subjectively described by the anaesthetist as being difficult intubations. And failed intubations occurred 1 in 312 patients. So that was 10 patients in total, 9 of whom had surgery continued with a supraglottic airway, and 1 was woken up and had a spinal anaesthetic attempted successfully by a more senior anaesthetist. What's a really important figure, I think, is that only 1.9% of all intubations were done with a video laryngoscope. And in fact, you find remarkably similar findings from a couple of other smaller but recent studies in France and South Africa. It's a very limited use of video laryngoscopy. There was a small handful of awake fiber optic intubations for predicted difficult airways in patients who had contraindications to neuraxial anesthesia, all of which were uncomplicated and successful. There were 2 suspected aspirations, but no mortality associated with any airway management for any of the 3,000 patients. So 10 patients had grade 4 laryngoscopy, 6 were rescued with a video laryngoscope, 2 rescued with a bougie, and 2 had failed intubations and had surgery continued with a second generation supraglottic airway. And I think you can find arguments for saying that you'd predict more frequent difficult intubations during the day because of planned care for anticipated difficult patients, or night because of less experienced anaesthetists manning the airway. Either way, there was actually slightly more frequent difficult airways during the day rather than night, likewise for a grade 3, 4 laryngoscopy, neither of which were statistically significantly different. So what I think is remarkable about these numbers is how little has changed over the past 20 or 30 years when you measure the same parameter. So there's a study 10 years ago run by UCOS that identified 57 failed intubations over a 2-year period of data capture and found an estimated incidence of failed intubation of 1 in 220. And then Mike Kinsella led a meta-analysis of international studies involving over 150,000 obstetric GA intubations and found an incidence of 1 in 390. As I said, from our study, it was 1 in 312. And also, if you look at data on availability of video laryngoscopy, then the most recent data suggests that only about half of labour wards have immediate access to a video laryngoscope. So my takeaway message is this. The tools that we have for averting this major problem in obstetric GA practice can't help unless we have them available and we use them. I think it's an immediate priority that we have video laryngoscopes available in labour ward theatres, and I'd suggest that if you're comfortable using them, then they should probably be your first line device for intubation. So now for the primary outcomes from the study, and this was actually published in the second results paper. So we found 12 patients with certain probable or possible awareness, which was an estimated incidence of 1 in 256. And this figure shows the Michigan awareness classification grades for those patients. So just over half of the patients found the experience distressing, and none of the patients who reported only hearing noises or voices or non-painful tactile sensations found it distressing. 2 patients reported pain. 2 patients reported pain with paralysis, and 4 reported paralysis alone. But that's 1 in 250 patients reporting some form of complaint around awareness during obstetric GA. So this is one of my favorite figures from the paper. So what this shows is the mismatch between characteristics in the ARGA group, which are the bars, and then the baseline activity in the activity survey, which are the dot and lines. So any column where the bar is below the dot means that that characteristic is underrepresented, and conversely, if it's higher, then it's overrepresented in the awareness group. So propofol was underrepresented in patients who reported awareness. Thio was overrepresented. Likewise, in opioid induction drug, was underrepresented in awareness patients compared with the baseline, and patients with a BMI of over 25 were overrepresented. And then the other very noticeable difference was night shift anesthesia. So 10 of all the 12 awareness patients had surgery during the night shift, so that's 8 p.m. to 8 a.m. And so we used a standardized measure of post-traumatic stress disorder symptom profiling called the PCL5 to measure psychological impact after surgery. And we measured this at 30 days and then in the awareness patients for 12 months, actually. And what this box plot shows is markedly different scores in terms of psychological distress between patients who reported awareness and the comparator group who had obstetric GAs but with no awareness. These are the individual PCL5 scores for the awareness patients, and the title in each bracket in bold is the MAC. So the higher numbers are for pain and paralysis, and the D denotes distress reported immediately during the procedure or during the experience. As a rule of thumb, any PCL5 score over 30 is highly likely to be associated with PTSD. And as you can see, those who describe distressing experiences tended to have quite prolonged consequences in terms of their psychological morbidity, with high PCL5 scores for at least 12 months afterwards. The exception is patient 6 on that list, so ID 6, who had high scores despite not being distressed during an episode of awareness during a prolonged difficult intubation attempt. And she was diagnosed with postpartum depression afterwards. Patient 7 described a very distressing experience of suffocation and paralysis during her induction, but actually didn't have any adverse later sequelae. And I think what this goes to show is that mental resilience against these types of experiences is very complex and difficult to measure, but overall immediate distress was associated with negative long-term psychological consequences. So I've got 5 minutes left. I'm just going to quickly spin you through a little bit more of the data from the study. What this shows is that the odds ratio of developing PTSD following awareness was 42 compared with non-ARGA controls. And I'll just very briefly show you a case study for one of our awareness patients as well. So she was a fit and well 32-year-old who had a CAT1 section, epidural top-up, and then converted to GA with a dose of 300 milligrams of thiopentone. What she described was actually a really detailed description of an RSI from a patient's perspective, including feeling unable to breathe and little details such as her neck being tilted back, feeling the laryngoscopy and then the fasciculations from a succinyphonium. And actually what this reports is very similar to the emotional descriptions of a lot of patients as well, that it wasn't necessarily the specific details of the sensory experience, but actually what was most distressing was being powerless to respond or communicate during the experience. So here's a couple of quotes from her follow-up interviews. And what she said was she felt out of control and guilty about a lot of things. And actually how her awareness experience was altering her future life decisions, including future family planning. And again, she had some very clear avoidance behaviors in the 12 months following her experience. including panic behaviours and self-discharge from hospital when she was admitted to rule out with chest pain to rule out a suspected PE. What this illustrates to me is just not just how obstetrics is high risk for awareness, but also the stakes involved and how those risks have profound effects on family life and future parenting choices for our patients too. And so very similarly to the NAP5 findings, we found that 3/4 of all the awareness events occurred during the dynamic phases of anesthesia, so during induction and emergence. And these were the experiences reported by patients. So often patients reported multiple different experiences. And around 2/3 of patients reported their experiences being unlike normal conscious perceptions, more like being in a dreamlike state. And as I've already said, I think that's completely understandable that women who are tired and suddenly thrust into unusual, uncomfortable environments have got very altered perceptions and memories of abnormal events. So awareness happens, it's scarily common, but what can we do about it? And how can we prevent it? And not just that, what can we improve in terms of the quality and safety of our obstetric GAs? So as I've already said, I think flyopentone's had its time. I think there's a mandate that video laryngoscopy should be available in labour ward theatres and probably used as a first-line tool for those who feel comfortable using them. I think that there are several cases of awareness that we found that involve prolonged paralysis during emergence, including one patient who had a previously undiagnosed pseudocholinesterase deficiency, yet nerve stimulating use is below optimal. I think there's a debate to be had around rocks and sucks for RSI, but actually I don't think that debate is especially important. I think each drug's got its own merits and problems. Clearly there's an issue around consent, and the Montgomery ruling in 2015 concerned obstetric practice of core shoulder dystocia. An event actually has an arguably similar incidence to awareness reported in our study. So logically it seems incumbent that we need to discuss this during the consent process. Clearly that can be very challenging, especially for category 1 sections, yet we know that those patients are the highest risk for ARGA, yet you may only be able to have a very abbreviated discussion about those risks prior to surgery. The staffing issue and the nocturnal awareness overrepresentation is a very complex issue, I think. And I think that as an aspirational standard, that obstetric GA should be a 2 anaesthetist technique, but there's no hiding from the fact that the vast majority of our reports occurred out of hours with non-consultant-led anaesthesia. Are trainees the problem? Of course not. What we need to do is work out how we can plan and prepare as a team to better mitigate against those understandable stresses and challenges that come from trainees leading difficult anaesthetic procedures alone at night. Simply extending consultant working patterns isn't necessarily the solution. There's a very obvious question around monitoring here. I'm personally a skeptic for the value of processed EEG like BIS to prevent awareness. I just don't believe that the evidence is good that it can discriminate well between different brain states that represent consciousness. And the processing algorithms are very easily fooled by electrical activity from outside the brain. There's also very little evidence for the index threshold for BIS that's relevant in OBS, and I think that could well be different for non-obstetric practice. And we're also working on some OAA consensus guidelines for obstetric GAs, so please watch that space, hopefully available in the next 12 months. So awareness is common. Around half of patients suffer psychological morbidity, and there's a gap to close between very heterogeneous obstetric GA practice across the country and what current evidence suggests is best practice. And if you want one takeaway, then thiopentone and out-of-hours surgery are associated with awareness. That's my time. That's all the content I wanted to cover, and I'm very happy to take some questions now as well. Thank you.
Many thanks, Peter, for a very informative and thought-provoking talk on the back of a very well-conducted study. My question may be predictable, and it really relates to what you think the barriers to change have been. from the classic RSI. So now we have the evidence, we have the science, we have the familiarity, but what do you think that the obstetric anaesthetist has been fearing, and what can the progressive anaesthetist take back to their traditionalist unit before these guidelines come out to try and change practice?
I mean, the classic RSI technique in obstetrics is almost something of a fossil, really, isn't it? It's been the same technique for 40, 50 years. And in some respects, that's a very strong motivator for some individuals to continue using that technique. It's served them well for decades. Why should they change now? And I think there is a big barrier in implementing evidence in obstetric practice, because actually evidence is very difficult to gather for obstetric GAs. It's very difficult to run the studies. There are very few of them. And even if you look at the randomized controlled trials that compare thio and propofol, then they're very small in number and include very few patients. So actually you can justify that it is very difficult to make robust evidence-based decisions from the data that's available at the moment, which is why you need to look a little bit further afield and use translational evidence from non-obstetric practice as well. As I've said, I think the evidence for propofol is now pretty convincing, but we've been saying this for years as well, haven't we? And what I hope that we have done with this study is take a very anesthetic focused complication and involve a lot of people in the study and use that as a real driver for change. And I actually know anecdotally that several of the trusts that were involved in the study conduct did make changes, kind of as a Hawthorne effect of being involved in the study, and did change and switch from thio to propofol during the conduct of the study. So I think putting focus on the area, building the evidence base for it is starting to have an impact. And certainly the data shows that there has been a big change in the course of the last 5 years. And I expect that to accelerate over the course of the next 5 years.
Yes. There's been another comment, more so than a question, from the group, that there's talk of the junior anaesthetist at night and the non-consultant practicing at night. What do you think? Do you think there's any impact from junior obstetricians in what happens at night?
So there may well be in terms of decision making. And what wasn't particularly well captured in the study was, I suspect that some of the category 2 sections were GAs because they were converted to category 1 sections in theatre. And I wonder whether actually having junior obstetricians may have an influence on that conversion rate, and the higher numbers of category 1 and 2 sections, or the high proportion of category 1 and 2 sections that occur at night. Given that the majority of the awareness experiences occurred during induction rather than maintenance, I think that we probably have to hold our hats up in terms of responsibility far more than the obstetricians. But yeah, it's an interesting thought.
Yeah. Well, if there aren't any more questions, the time is up. Thank you very much again, and I'll hand you back to Kay.
Thank you, Peter, for your excellent presentation. And I do just want to commend you on such an important piece of work on our understanding of awareness in obstetrics. So moving on to our second speaker, it is a great privilege to introduce Mr. Kevin Phillips. So Kevin has over 30 years clinical experience in obstetric and gynecology. He's been a consultant in Hull and East Yorkshire hospitals since October 1996. In addition to all his extensive clinical experience, he's been very involved in medical management. He was the Chief Medical Officer in Hull University Teaching Hospitals from 2015 to 2018. And during this time, he was the Senior Responsible Owner and the Clinical Lead for the local maternity system until April of this year. So it's with great pleasure that I pass you over to Kevin.
Good morning, everybody, and I hope you can hear me and see my screen. So I'm just going to get myself off a little bit. So I'm going to talk a little bit about the Humber Coast and Vale LMS and what my knowledge of the others across the region. In Yorkshire, there are 3 local maternity systems. Across the country, there are 44. And how we've responded to the recent Ockenden report is important, but I think the context of why we've got to this position is also important. So I'm going to take us back to the stimulus for looking at recommendations in obstetrics and why we need to be trying to improve talk. And much of this is relevant to whatever specialty you're in. I'm not obviously not removing obstetric anaesthesia from that. So this is not just obstetricians and midwives, but across the board. So the 2016 recommendations were in response to maternity services appearing to be outliers to other similar countries, and reports produced. Then Baroness Cumberledge reported back to the government saying, look, you know, the areas of concern are we don't have personalised care. So that's talking about women actually having been involved in a full discussion about their care and about what they want and how that's going to be delivered to them. So I think we've traditionally in medicine have taken a view that we say this is the way we deal with a particular problem, rather than have the person centred to that problem. There was quite a lot about continuity of care, and certainly this has led some of the obstetricians to worry a bit about continuity of care, because the only study that was done on this was there were a few put together as a meta-analysis by one particular person, and that was looking at the continuity of care for the low-risk women, for those who didn't end up with complex obstetric problems. And it showed that you could reduce stillbirth rates, you could reduce interventions in labour, and in particular for relevance to yourselves, there was a significant reduction in epidural rates required. So that continuity of care means really having the same person both involved in your care antenatally, intrapartum and postnatally. That doesn't always mean that is the only person who's involved in those stages, but at least the woman was aware and had some confidence in that. Cumberledge also thought that we could be a lot safer in obstetrics, and in particular for the perinatal mental health issues, there were a lot of problems associated with postnatal and perinatal mental health, which is kind of similar across the board of the way we deal with people with mental health problems in medicine in general. And there were big gaps for those. And that reflected in the Embrace report, recent report, that actually suicide and mental health problems are one of the leading causes of maternal deaths. Isolated individuals working rather than a multi-professional working pattern, so that's using midwives, obstetricians, and working across boundaries and learning from other areas, because most things that go wrong in obstetrics are relatively rare. So if you've got a unit of 3,000 deliveries, then by default, if we look at the previous speakers' talks, then a 1 in 312 risk of having a failed intubation, and only a small proportion of those patients have category 1 or category 2 sections, then you're actually probably only going to come across that once every few years in an average sized maternity unit. But you might learn across the board. And there was also a question about the payment system, whether that was incentivising better care for women with complex needs. And the case for change was that the number of births seemed to be increasing, as was the age of first pregnancy. So that had gone up in 1982 from 27 years to just over 30 by 2014. And over that period of time, obesity, diabetes, and other complex problems were also occurring more often. We've talked a little bit about this. The staffing also looked as if wasn't as good as it could be. 1,970 obstetric consultants in the UK, 1,630 trainees. And we've talked a little bit about just previously about the need for maybe obstetric anaesthetists at consultant level being available 24 hours a day. Certainly there's a big move towards that in obstetrics. And there has been for a number of years, but more recent RCOG curricular changes have meant that you've really got some of the procedures where obstetric trainees, you would have been happy with them doing procedures such as taking a woman for a trial of forceps from the delivery suite to theatres would have been an accepted thing for a senior trainee to do. Now it's almost not, and you need a consultant there. So this has driven the need for 24-hour consultant presence on labour ward greater and greater. So I think that's an area we're going to talk about, the increase in numbers there. There have been increasing numbers of midwives required for a long term, and there is certainly a feeling that will significantly rise, perhaps up to something like 40,000 before rotas are changed and there are changes in the requirements for midwives, but it will still probably be more full-term equivalent midwives than it is today. The quality assessment looked at stillbirths and neonatal deaths needing to come down, and indeed this has happened somewhat. Maternal mortality also has fallen over the years, and interestingly the conception rate for under 18s is down, so that's kind of suggests that we're better at looking at these higher risk group of under 18s and having better contraception, availability of contraception, and therefore the need therefore these young women becoming pregnant has fallen over the years. The stillbirths was one element of the better births regime that we have to demonstrate a fall. And if you look at other countries around Europe, first world countries around Europe that have similar populations to ourselves, our stillbirth rate was almost double that of some countries such as the Scandinavian countries. So there must be something that was done differently in these countries, or our population was different. Just as another little guide, 3rd and 4th degree obstetric tears, so that's involving the rectum in some way. Big variation across the country as well, right from some units having less than 3% of their women having obstetric tears to others having 11%. So we need to understand a little bit of that. And the CQC also came round and said that maternity safety assessments were either inadequate in 7% or required improvement in 41%. So that suggested that almost half of the units assessed by CQC required some sort of improvement to their management of obstetric patients and maternity patients. And the areas of concern are nothing new to anybody. Learning lessons, culture, staffing, this variation, but more to the point, not having named carers that were known to the women, because that does seem to make a difference in the outcomes as well. I'm not sure of the science behind that, but there is a definite change there. So there's been some initiatives to reduce stillbirths and preterm births, which are the main problems that we have. And as I said before, the Department of Health looked at 50% reduction in stillbirths and neonatal deaths by 2030. They subsequently moved the goalposts, a bit like with climate change and everything else. They moved the goalpost down a bit, and it's now 2025. This is very much based on something called the Saving Babies' Lives Care Bundle, which now is in its second version. But it's looking at smoking in pregnancy, fetal growth restriction, reduced fetal movements, and how we monitor women and how we assess that monitoring. Interestingly, from a smoking in pregnancy point of view, we had started with a kind of quite a worrying sort of level of smoking in pregnancy and smoking in delivery throughout the country of over 16%. In Yorkshire and Humber, that was nearly 25% of women were smoking when they came to deliver their baby. Now that has fallen down to somewhere around about 14 or 15% in Yorkshire and Humber, and it's fallen overall in the England to 10.6%. But there is still a drive towards getting closer to 6% as our target figure. So despite stillbirth falling, despite the maternal deaths falling, there's still room for improvement. But interestingly, 4 years on, women did report their feeling safer during that. There was better mental health support. And HSIB, the Health Service Investigation Bureau, are looking at all babies born either stillbirths or with brain injuries and coming out with the report. So this is kind of looking at everything nationally and coming out with a report, because these are relatively rare individual events. And that's set up in a very similar way to the Air Investigation Bureau. So every time you crash an airplane crashes, the team goes out there and looks at holistically around why that happened, and then similar sort of things are now happening in medicine, and this has started in maternity. So the risk factors that we're not surprised. 50% of women booking in 2016, 2017 had a BMI which was considered either overweight or obese. And that was increasing from a year earlier. And I'm sure that most of you have come across this. Diabetes rates, which are probably related to obesity, have also increased. The stillbirth rate has fallen a bit, but Yorkshire and Humber a little bit below the stillbirth rate, but a little bit higher on neonatal mortality. And as I've said before, the smoking and delivery is going down, but not as fast as we would like. So we're going to talk a little bit about the Ockenden report, and the first 250 cases have got some analysis to those. When they first went into Shrewsbury and Telford, they thought they would be dealing with something like about maybe 10 to 30 cases. That expanded up to over 200, and more recently they've started looking at over 1,700 cases where the outcomes have perhaps not been as good as they could have been. Baroness Ockenden's report really came across because there was a letter to the then Health Secretary, Jeremy Hunt, expressing concerns about care. And that was from the families of either the families of babies that had died, but in particular two parents of two women who had died in pregnancy. So they were considered maternal deaths. And it was felt that they hadn't really been looked at properly. There were some gaps in the care, and there were concerns about the care. So that was the stimulus to this letter to Jeremy Hunt, and it's progressed on from there. Now, the next few slides are going to just explain a little bit about why we continue to look at things, but we do very little about them. And I'm sure that many of you working across the Yorkshire and Humber area, and you could be anywhere in the UK actually, would have the same problem. For Shrewsbury and Telford, where the Auckland report reported, there have been 10 CEOs of the trust from 2000 to early 2020. That is a significant turnover. During that time, there have also been 10 trust board chairs. So one of the first things was this lack of continuity, and it had contributed to the problems not being addressed within that trust. So there were well-known problems, but obviously every time a new CEO came in, nothing much happened. And they assumed that all of the actions had been taken by the previous CEO, trust board chair, so there was very little continuity, and they wanted to look at how they were going to improve the whole trust. Interestingly, and not surprisingly, as many of us have been involved with CQC visits in the past, 2015, the CQC went into Shrewsbury and Telford as part of the routine checks and said maternity services were good. Well, clearly most of these cases happened before 2015. So somehow the presentation on the day or on the week that CQC went in was such that actually they missed all of the things that had previously happened. However, by 2018 and 2020, they did start to talk of in the well-led domain, the trust being inadequate. Mandatory training for all staffing was not up to date. High risk women were not seen by the correct person in the correct place. There was poor grading of incidents, and there was poor one-to-one care of all women in labour. So there was an action plan drawn up by the CEC, but there seems to have been little follow-up of that. And the trust was able to describe what they were trying to do, and the CQC accepted that without necessarily saying, well, actually, it should be done by now. Embrace, even back at the triennial report into maternal deaths in 2013 to 2016, showed that there was 10% higher maternal deaths compared with comparable trusts. This had stabilised a bit by 2017, but they knew quite a long time ago that there was also some concerns. The CCGs, there are two now in the local area. One in 2013 at its inaugural board meeting raised concerns about maternity services. So these were well-known problems in that organisation. But the checks and balances that we have clearly did not help. There was an internal review as well into maternity services. The RCAG became involved in that review as well. And there were patient safety actions all over the place. So one of the recommendations that these need to be in one action plan. There needs to be a coordinated approach to maternity safety. The safety of patients was often protected by the efforts of the staff. and these efforts were supported by their leaders, but they didn't really address the fundamental reasons why there was a problem there in the first place. So often it was staff who protected and helped deliver the patients safely or the women safely without necessarily addressing the underlying problems. And I mean, I think that might have been reflected a little bit by the COVID problems we've had, in particular last year, where actually the staff really stood up to working quite hard in the NHS to look after the safety of patients. But there wasn't always an underlying thought pattern about how could we address these things better in the future, so that, yes, staff may need to step up, but not to the same extent. And after a review of the actions, and this is a really important thing to understand, and to reflect on your own areas, our midwives felt to be the specialists in the provision of normal pregnancy obstetricians and the clinical leaders for complex pregnancy care. But do they work in isolation or do they work together? That is the question. And although there was a recognition that these midwives have specialist roles and obstetricians have specialist roles, there was very little coordination between the two. So the emergent themes from the Ockenden report showed that there was no risk assessment being done at each visit. Compassion and kindness had been lost. So a lot of the time we were talking down to the couple, and both midwifery and obstetrics. And I think in the kindness thing, a couple had just lost their baby, and there was a letter was sent to them to say, I understand you've just lost your baby. Would you like an appointment with me in the clinic? We can fit you in at such a time in 6 weeks' time or whatever, rather than apologising for the loss, showing some kindness with that. And it's quite distressing to hear some of the things that were said about the care of patients there. But I think we could all probably reflect on ourselves and our own units. Will we address things better? And we might think we do, but actually when we look at care, we may find that we're not quite as good as we think. There was a failure to recognise deviation from the norm, very poor consultant oversight. A lot of the consultants didn't come in to help the junior staff on labour ward. And frequently the junior staff then didn't escalate care. They didn't ask for help neither. So by not being present and not being helpful, the juniors' line was, let's not bother the consultant. And I think there's a balance between those escalation of care and poor consultant oversight, and it's probably been available, and that helps the escalation of care go through the correct pathway. Management of labour and fetal well-being was another big problem there. CTGs were not being looked at in the normal way with fresh eyes. There was use of oxytocin to try and get women to deliver. In many units, they would have gone for a cesarean section. All attempts were made to deliver these women, and that was reflected in the traumatic birth rate. The cesarean section rate was about 11% overall, where in the rest of the UK at that time, it was 20+%. So again, that is a dramatic difference between the Shrewsbury-Telford unit and the rest of the country. And why were people not questioning that? As the chief medical officer, I used to often be questioned about why our caesarean section rate in Hull seemed to be slightly above the national average. And there was a big drive to make that as low as possible. Well, actually, it was probably at the right rate, considering the population base. And so we try and defend that on an increasing obesity, increased diabetes, and more difficulties in fetal monitoring, and more difficulties in understanding growth restriction in these patients. So we looked at everything was being looked at there. Aren't they great? Haven't they got a low caesarean section rate? Rather than why is it so low compared with everybody else? The bereavement care was just a shambles, really. There's nothing else can be said about that. There was no coordinated bereavement care. So even after you'd lost your baby or a maternal death had happened, there was no coordinated bereavement care in the trust. So we're going to just have a little look at some local actions which were given to them, which I think are important for the national way of trying to deal with pregnancy problems. The risk assessments were poor. Staff were not looking at contemporaneous evidence-based information. There didn't seem to be a lead midwife or lead obstetrician in place. There wasn't very good compliance with the Saving Babies' Lives Care Bundle. They didn't use the NICE guidance on fetal monitoring. There didn't appear to be appropriate clinical governance. Consultants were often not involved in the complex pregnancies and delivery. And I think you might want to ask yourselves, do 2 ward rounds happen in your labour ward every time you're there? And are those multidisciplinary? I know that many units have at least once that happens, but actually the recommendation is that should happen at least twice in 24 hours. So the maternal deaths there didn't appear to be any SOP for junior obstetric staff and a guide to escalation, and it didn't really matter when that happened. 24 hours a day, 7 days a week, it should be happening, and there should be a clear escalation guide. And the recommendation was that needs to be audited annually, that actually it is happening. There needs to be some sort of MDT for women with comorbidities, an agreed plan, and there needs to be a named consultant with expertise in the care of high-risk maternities. Interestingly, in the Ockenden report, there was quite a bit also about obstetric anaesthesia, which may be more relevant to yourselves. We know that 60% of women entering labour ward require some anaesthetic intervention. So I want you to go away and think, have you got appropriate consultant cover for your junior staff? Is there always a duty anaesthetist who doesn't have any other tasks to do available for labour ward 24 hours a day, 7 days a week? And as many of you will clearly recognise, that obstetricians tend to defer to the anaesthetist, the obstetric anaesthetists, about the management of peripartum medical problems. And so the anaesthetists are not peripartum physicians, yet we as obstetricians often imagine they are. And there is a little bit of a drive to obstetric physicians, because you can say the same about a cardiologist or a renal physician who sees hardly anybody with any obstetric problems. They just happen to be the one on call, and therefore maybe their understanding of the physiology of an obstetric patient is not well understood, and they may want to manage things in the same way as they would manage a person who's not pregnant, but actually that isn't necessarily the right thing to do. So there is a little drive about trying to get physicians who have some special training in the physiology of obstetrics to help support these difficult areas that we often find ourselves in as women, in particular as women get older, who deliver. I think you'll often find this, that the trust and the anaesthetists in particular find it as a task-orientated problem. So you've got to give a GA for this delivery because actually there is a major problem with the baby and that we must be delivering the baby. And there was an example of the very thing happening there, rapidly progressing preeclampsia. A GA was given, the BP was not controlled before that, but there was pressure on delivery of the baby. And what happens is the baby is delivered, but the mother then has a stroke. And so we should have managed the BP problems first. You know, we've discussed this a little bit previously as well, about considering what the CTG abnormalities are. So, you know, there's a woman wanting an epidural. Actually, she wanted to push it. I've missed an N out there. She wanted to push at the time. There were already CTG abnormalities, but the CTG was stopped because the band was around her tummy and was in the way of the epidural. So there was no thought then that actually should we be examining the baby, the patient, maybe she needs delivery. There was often lack of escalation to senior anaesthetists. And when escalated, the consultant didn't attend in a timely manner neither. And I think this is where we could do with improvement across the board. There is often very limited representation in incident investigation by the anaesthetic staff who might have been available, who might have been involved in that care at that time. So just to finish off, these are the essential actions that for all maternal and paternal services. And I've looked in yellow here, these are the areas across the board of the LMSs, and certainly in our region where I'm not sure that we've really got this sorted out. Most are using dashboards, most of guideline groups formed, and there's a formal agenda item for maternal safety on every LMS board or some sort of formal agenda item there. I think there is a big drive to the LMS having greater responsibility and accountability, and most people know that. But I'm not sure if the chair, one of the recommendations was the chair must hold a CCG board level membership. Yes, we have representation from CCGs, but I'm not sure if they have board level membership. All maternity SIs must be sent through to trust boards and the LMS for scrutiny of its own transparency. And again, I'm not sure if that universally happens at the moment. There is a degree of scrutiny within the LMS, but I'm not sure if that is happening to trust boards. Are women in families listened to? I think there is a drive towards creating senior advocates in trusts and LMS boards, but are they available to every family for follow-up meetings when they've had a loss or a bereavement or a difficult delivery? I suspect not. We haven't got evidence that they are. Most places have managed to get a non-exec director who is the maternity safety champion on their boards. How they interact with the maternity services, how often they meet, I'm less certain about that. MVP is Maternal Voices Partnership, so that's the women who've recently delivered. who want to discuss maternity care. The CQC have said that they want to hear the women's voices that are heard. And I think that has been a drive of the LMS is around the country, but I'm not sure if that's still the case. And staff training together, I think that does happen. Is there clear evidence to the LMS that happens? Things like the twice daily multidisciplinary rounds, which are consultant led, I'm less certain about. I think you could probably say most units will have a once daily round. I'm not always certain, and you can tell me whether always anaesthetists are involved in that. I don't think trusts necessarily ring fence the training budget for maternity staff, and that would include the anaesthetic staff. I think trusts tend to have this there in the background, and as a rule, there hasn't been a major problem with funding for training, but there is, I would still say there's a question about whether that's really ring fenced or not. Robust pathways for managing complex pregnancies. There are some pathways in place. How well they are, that's less clear. We haven't developed tertiary level maternal medicine centres everywhere around the country. I am not certain whether risk assessments are documented at each visit. We have many units will have lead midwives for fetal monitoring. I'm not sure if they've all got lead obstetricians for fetal monitoring. And this is very much a CCG driven thing. Nice guidance would suggest that women with full informed consent should have the choice for caesarean section. And many CCGs will not fund that. So that's always a difficult area, but it is in the nice guidance. So just leave you with these questions, really. Did the trust have in place at the time of incidents for governance and oversight of each incident? Does it have it now? And I want you to think about those questions here. Is there evidence of learning from incidents? Were incidents reported and concluded in line with national policies? And were families involved in the investigations in appropriate and sympathetic ways? So we'll leave it at that. Any questions? And I'm happy to take them.
Thank you very much, Kevin. That's better. We've got your camera on your face now. That's great.
Oh, sorry.
No, it's fine. It's absolutely fine. So thank you very much for a comprehensive review of national and local maternity services in response to a report that is very difficult reading. Absolutely essential, but very difficult and should be read by all involved in caring for these women. What struck me, compared to my working day, is that a lot of our challenges where I work are around staffing levels. In terms of theatre staff, not enough midwives, elective section lists not running efficiently because of staff numbers. And the Ockenden report didn't really focus on that, did it? There seemed to be the people there, but they weren't being escalated to. And I was quite pleased that it wasn't a knee-jerk reaction of we need thousands of more midwives. Have you any comment on that about staffing levels and the impact of what was happening in Shrewsbury and Telford?
So I think in Shrewsbury and Telford, I'm not 100% sure of their staffing levels. As you correctly said, there wasn't a problem with there wasn't deemed to be a problem with the number of staff. I think it was coordination between staffing groups. However, the LMS around the country and the national maternity services around the country recognise that there needs to be an increase in both obstetricians and midwives to deliver obstetric care in the future. There is a little bit of thought from Health Education England that this will improve as we look at changing rotas, in particular midwives, to more continuity of care, but they haven't got a clear way of getting to a better point in the interim time. And we know, and you probably already know this, that many nurses and midwives are using the opportunity to retire at the age of 55 before they get caught up in you've got to work to your 67 or whatever. So, and that's happening now. So that there's this big bank of midwives and nursing staff in particular at around about the age sort of early 50s who are wanting to retire, and that is a big problem area that we've got. And I don't feel that's been truly addressed by our staffing now. Locally, we do have a stream of our STP, when it started, it's now an ICS, looking at staffing across the board, but how specific they are to obstetrics, I'm less certain about. Now, a number of years ago, people tried really hard to say these are the lines, the RCOG said these are the lines that big units that are tertiary centres that deliver more than 5,000 deliveries per year need to have 24-hour consultant care on labour ward. But actually, it became more of a problem. So it's a slightly different tact they've done now of saying, well, actually, junior staff have got to be supervised until they're completely signed off to be independent practitioners. Yes. And by the curriculum changes, that's not going to happen until they're ST 6 or 7 at the earliest. So any labour ward that has ST 3s, 4s, and to a degree 5s are unlikely to be signed off. And therefore, there's a drive around the country that we need more consultant presence on labour ward. And that's obviously an expense for each individual trust because they've got to find the money for that. But yes. And I don't think we're going to be that far. I know there's been a little bit of resistance anaesthetically, but I don't think you're that far from being behind us about having 24-hour consultant or senior and anaesthetic cover to labour ward.
Yes. Thank you very much indeed. I'll hand you back to Kay.
What makes our lives better? What really influences us? We're captivated by great events. Global, dramatic, uncompromising. Great events don't just happen. We make them great. We make them what they are. But often they only outshine what really matters. The really great things are hardly visible to the naked eye. Therein lies their power. The power to make things happen. Subtle, but focused. Without the desire for attention, solely serving the cause. They do their work under the cloak of seeming insignificance. But the unpretentious details carry a special magic within them. It works because we are under its spell without knowing it. And you know nothing about us either. We were born from an idea, fed with passion, and raised to vision. A vision to ease pain. It took courage for us to come true. Against all opinions and hurdles, we were created to do good. There are hundreds of us, thousands. We're almost unnoticeable, and our strongest feature measures only a few microns. We are proof that mutual trust and appreciation can defy all resistance and bring about change. Subtle, but focused, without the desire for attention, solely serving the cause. We push things forward. We are Payunk.
Welcome back, everyone. I'm Anju Rana. I'm a consultant anesthetist at Hull University Teaching Hospitals, and I'm going to be chairing this session and another interesting session, experts from hepatology, followed by an expert from cardiology. I'm pleased to introduce our first speaker, Dr. Charlie Milson, who is the clinical lead in hepatology at York Teaching Hospitals. Dr. Milson trained in hepatology in London and Yorkshire before taking up his first consultant post on the Leeds liver transplant unit. After 13 years in Leeds, he moved to York to set up the liver services. He was senior author on the recent UK liver transplant guideline, but his research interests these days are focused on risk stratification to aid identification of undiagnosed liver disease. He's going to be talking on acquired liver disease in pregnancy. Over to you, Dr. Milson.
Thank you very much, Anju. That's a very kind introduction. I hope I'm worthy of all that. Let me just share the. I think we're in business there. So yeah, thanks very much to the organisers for asking me to speak on this and hopefully share some wisdom over this. So I just wanted to just to talk a little bit about my experience of obstetrics. Those of you with good resolution on your computers can tell that I'm not the youngest of the speakers today. And I did do a bit of obstetrics, but that was about 30 years ago. When I spent a year away in East Africa, and I arrived, and I was suddenly the surgeon, the anaesthetist, and the obstetrician, as well as doing the paediatrics and the adult medicine, which I had planned for. So I did a bit of obstetrics, and I found it all very messy and quite difficult. But I also had a little bit of exposure to anaesthesia as well. But it was quite ancient anaesthesia, and therefore I have no expertise in anaesthesia. But I will just point out that our main obstetric anaesthetic at that point was a spinal needle and some of this heavy lignocaine here, which did give some exciting complications every now and then. So, and this is an ether draw over machine for those of you who. I'm sure you're all very familiar with that. So let's just move on to something I do know a little bit about, and that's the liver and pregnancy. Now, liver disease occurs obviously outside of pregnancy. I'm not going to talk much about that, except for a couple of important things I think we should all remember. I'm not going to talk about, therefore, about liver disease that's present before pregnancy, or those necessarily that are coincidental with pregnancy, although I'm going to mention a couple of things later on in the talk. And then I'm going to mainly focus on things that are exclusive to pregnancy. And I'm going to do that. I'm going to start that with just pointing out a couple of things, and that is our population is getting larger. I know that will come as no big surprise, but I point this out as 3 weeks ago, I was referred my first patient to see with abnormal liver blood tests in pregnancy, who had a BMI of 50.2, I think. Now, apart from kind of puzzling about the mechanics of that, there is obviously issues around a pregnancy within an abdomen that is quite that large, and I reflected at the time that I hadn't seen a great number of people with BMIs of 50, and in the last 2 weeks, I just happened to have seen 3 people with a BMI of 50. So I think that's an important thing to remember as we that over the next 10, 20, 30 years, this curve is obviously going to carry on going up, and those patients are going to present to us in our maternity clinics. And of course, the thing to remember about that is that the percentage of patients who have fatty liver disease in that group is 100%. Every patient who's got obesity has a degree of fatty liver. So that's their starting point. And then just one other plug, because I am a liver doctor these days, is for alcohol. Now, those of us who struggled through, most of us who have actually obviously still been working through the COVID and last year will likely be aware that a lot of patients took solace in the bottle over the last 12 months. So our admissions for alcohol-related liver disease have gone up significantly. But I would just point out that over the last, I just wanted to give you these 4 pictures just to remind us that alcohol is cheaper, certainly a lot cheaper than it was 30, 40 years ago. We're consuming more, and as shown here, and we're consuming more, and that means, if you look at this isn't at the detriment of other less dangerous alcohol types. We're just consuming more, full stop. And our death rate, which looked like it had come down, is actually now heading up, and we expect that over the next 2 to 3 years that will continue to rise. So just to bear that in mind, and then to move on to the important stuff. First of all, the normal changes that we expect to see in pregnancy. The most important one from a liver doctor's point of view is that the albumin drops. Now, normally when I'm looking at my liver patient population, when the albumin starts to drop, I begin to get anxious, because I know that in chronic liver disease, obviously a drop in albumin has serious ramifications. Now in pregnancy, that's obviously routine, and I have to switch off my anxiety alarm when I see these perfectly healthy pregnant women in their second and midway through their pregnancy with albumins of 30 or 31. The other important thing to remember is that the alk phos rise from the placenta towards the end of the 3rd trimester. I still do get an occasional referral to investigate that. And then one more is the platelet count, which in general terms, the platelet count drops off slightly in pregnancy. And again, a dropping platelet count to a liver doctor does ring alarm bells. So that's the significance of that is, and as I say, I have to remind myself that that's quite a normal a manifestation in normal pregnancy. So when I'm asked to see patients under these circumstances, pregnant patients, what do I think about? Well, I'm afraid, do the simple things first and do them well. I always ask about medications. Part of my training I spent before I came up to Yorkshire was at the Royal Free, and the Hampstead population were forever amazing me with the range of different tablets, ointments, pretty much anything that you care to mention that could be ground up, emulsified, or taken as a health remedy. And they would swallow those, I'm afraid, much more frequently. They would swallow any of the tablets I suggested might be good for their liver. Yak toenail clippings or some such. Just ask about all new medications, all new health remedies, anything. And of course, these are now a lot more readily accessible through packages coming through the post from around the country. So that I always ask about that. I always ask specifically about alcohol intake as well. I take a clear alcohol history, and I always ask about what it was in pregnant patients up until the point that they were actually pregnant, because and the relevance of that will come later on in the talk. And then there's the usual stuff about pregnancy, obviously gestation, new partners, multips, all the rest of it. I tend to ask about pruritus, but as we're going to hear, and for those of you who've been through this, you're very well aware that that's a pretty common symptom. Abdominal pain, again, pretty common, and then the other things are specifically about headaches, and any kind of cerebral kind of changes, if you like, or anything that they've not experienced before. Examination is usually pretty useless, I find, in this group of patients. We all see spider nevi, and I think I spelled that incorrectly, but spider nevi and palmareathema as a normal part of pregnancy, so they're not all riddled with advanced liver disease at all. Jaundice, however, is obviously abnormal, except for those women who have Gilbert's. And Gilbert's is Gilbert's syndrome, the unconjugated hyperbilirubinemia, is obviously very common, and that obviously will appear more profoundly in our patients when they are vomiting or stressed in any other way, and pregnancy is a pretty good stress. So just bear that in mind. So isolated hyperbilirubinemia, worth just checking the unconjugated conjugated ratio, and then hypertension and edema. Usual group of investigations, the usual blood tests. I would say that in this day and age, I also check for specifically in pregnancy for Hep E, CMV, and EBV. We've had probably about 5 or 6 EBV hepatitises earlier this year, which is, relatively, that's a cluster. I'm not sure it counts as an outbreak, but it's a relatively good number, and I suspect that might reflect us all being cooped up together a little bit more. Okay, let's just move on now to the liver diseases that do occur in specific to pregnancy. I'm just going to start with hyperemesis, and just remind ourselves of how that presents. Now, vomiting in early pregnancy, pretty common. This is said to be more common in overweight multiparous women with multiparous with multiple births. Now, I think, as I say, a third of our adults are now overweight, if not obese. So that is not an uncommon finding, I would suggest. Relatively common, up to 3 per 100 in pregnancies in the UK. And I think the ones that end up being referred to me, and my supposition is that I don't get anything like this number come across my desk. The reason why that is, I think, is that they're mainly just incorporated and managed very effectively in the antenatal clinics. Now, the ones that do make it and do get referrals from us are usually, by the time I get to see them, their weight loss is profound, their dehydration is profound, and they often have quite significant electrolyte abnormalities, which just that it is rare. I mean, I was just thinking when I was preparing this talk, when was the last time I'd seen, and I think I saw one. I think I was referred one about 2 years ago along these lines. So, what might those deficiencies be? Well, vitamin B and thiamine. One of the first papers I wrote was a case report that I saw when I was an SHO of a woman with a twin pregnancy who developed Wernicke's encephalopathy. And that was due to hyperemesis, and she did get to term and she did deliver, but it was quite profound, her vomiting, and I know that there are, there's capacity, or there's process for those people who absolutely cannot stop vomiting throughout pregnancy for patients to have, TPN feeding or whatever, alternative routes of getting nutrition in order to avoid the gut if absolutely necessary. So, I suppose one of the messages is never a reason to terminate pregnancy. The LFTs are abnormal in about half of these, but they're usually relatively modest. So we're seeing ALT enzymes of perhaps 150, 200, something of that order, and they generally don't tend to go much higher than that. I think the LFTs have to be monitored weekly, alternate weekly, something like that, while the problem persists, and just to keep an eye on things. But at this very early end of pregnancies, most of the other more worrying elements are not there. So generally, what to do: rehydrate, antiemetics, and press on, and hope it all works out for the best. And some of these patients, as I say, intermittently might need inpatient stay. They might need IV fluids. They might need, but I think it has to be taken on a on a case-by-case basis. And the majority of our patients obviously get away without anything such quite so aggressive. Now, obstetric cholestasis, bit more of an issue. Typically, and I've written typically, I think, by most of these conditions, simply because I'm not sure anymore that we believe that these diseases are kind of exist in silos, if you like. I think they. We'll talk about this in a minute, but I think there are features of all these conditions that we see that merge across. And I've certainly seen obstetric cholestasis in women who are in the low 20s of their 20 weeks of their pregnancy. Of course, pregnancy and pruritus is not unknown, and I suppose the more typical thing is that it tends to be the hands and the feet, and it tends to be worse at night. And I have seen patients presenting under those circumstances, and they have raked their skin. It's like we see one of the conditions we see a lot of in our liver clinic is primary biliary cholangitis, and typically those usually women will present with skin that looks like someone has been over there with a garden rake, and that's what you see with these poor women. The ALT tends to go up, and the bile salts often can go up 30, 50, 80, sometimes 100 fold. So the bile salts can go up really quite dramatically. I just check that there's no other cause of pruritus. And if the LFTs are normal, I usually say alternate weekly LFTs. If they're abnormal, I think it's wise to keep an eye on them every week, and they do fluctuate. But these numbers generally stay in the low hundreds. So these are not cases usually that you are biting your fingernails over. I give them all. So I obviously tell them. I warn them that it's not ursodeoxycholic acid is not licensed in pregnancy, but I do. That's the standard of treatment there. There's a few other things that have been tried, but that's what I find most effective now. And and obviously there's the risk of prematurity, perinatal death, fetal distress, etc. And I think the optimal, as I've written in here, the optimal time to call time is got to be a bit of a discussion between yourselves, between obviously the wider team, and the dependent on the size of the baby, etc. But in the main, try and press on with pregnancy for as long as possible. Now, what about fatty liver pregnancy? So. Again, 26 weeks. Supposedly, I've seen AFLP in women in their 20th week of pregnancy. So I think it's said to be about 26 weeks, but I've certainly seen it before then. One of the rarer ones, multiple pregnancies, first pregnancies. What about the symptoms? I think we're getting onto things. The thing that I think of that really kind of draws my interest and worries me is that I think for this group of patients is the symptom is the right upper quadrant pain, along with the nausea and vomiting and the headaches. But really, it's the right upper quadrant pain that begins. Now, if you ask pregnant women, do they have pain in the right upper quadrant? Most of their hands will go up, obviously. But this seems to be a more profound pain, and it doesn't seem to vary. They can get jaundice, they can get liver failure, they can get preeclampsia, and I think this is again one of these group of 3 diseases where the actual strict differentiation is perhaps not that helpful. The ALT enzyme generally up to about 400 or 500, and the serum uric acid goes up. Now, the ultrasound scan of a fatty liver, I've just told you 1/3 of the adults in this country are overweight or obese. So a fatty liver will be seen in all those women as well. So I'm not sure an ultrasound scan is particularly helpful for that reason. But in women presenting in pregnancy who've got right upper quadrant pain, an ultrasound scan I think is valuable to make sure they haven't got a gallbladder full of gallstones and or a bile duct that is full of gallstones. So I think from that point of view, an ultrasound scan is handy. And also just to remind ourselves that in low albumin states, the gallbladder itself generally tends to become edematous and boggy. So our normal ultrasound scan report that says thick wall gallbladder, send off to the surgeons and get the gallbladder out or whatever, that doesn't really count for this group of patients, as their gallbladders in the low albumin state will tend to be a bit edematous as well. I've certainly done one medical legal case where the gastroenterologist concerned sent the patient off to have an emergency cholecystectomy for the edematous gallbladder. Thought that thinking that the acute cholecystitis was the explanation for the deranged liver function tests, and that I'm afraid did not end well. I think the delivering ASAP, which is again a theme that we'll come back to. I think, remember, don't take your eye off the ball after the delivery. Continue to monitor mum, and as we all know, the maternal and fetal mortality for this condition is worryingly high. So preeclampsia and eclampsia, or PIH, or whatever it's called these days, I think the sort of triptych of hypertension, proteinuria, and edema, well known to us. Again, perhaps a little bit earlier in acute fatty liver. In various stages, perhaps a bit more common, but in its most extreme forms, thankfully, pretty rare. I think the symptoms and signs, usually keep a close eye on the blood pressure. One of the things I do remember about the year I spent trying to be an obstetrician in East Africa was that the standard blood pressure for all the women in the antenatal clinic, their systolic was usually between 80 and 85. Hypertension in that group of patients, and it was a fairly remote area of East Africa, hypertension for them really started around about 100, 105 really. What investigations they do? Well, generally the ALT is significantly raised, and I think you have to think about this as being more of a multi-system disorder. The platelets generally go down, i.e. further than one would normally expect, and there's an element of hemolysis. And of course, this whole syndrome bleeds into, if you'll pardon the use of English, the HELP syndrome, and also obviously into acute fatty liver. Cerebral involvement, ruptured liver. We had one of those in York a couple of years back. Low birth weight can introduce iron growth retardation. So all these sort of things. I think the critical thing here, what I tend to think about when I'm seeing these patients, first of all, to have monitored very closely the renal function. Of course, we expect the urea to drop a little bit during pregnancy, so keep a really close eye on the renal function, control the blood pressure, deliver when safe. So resuscitate the patient, do as much of the, if you like, of the control, the simple things, and then can't impress enough upon continuing to watch the patient after delivery. I've seen, and when I was a consultant in Leeds, we had one lady. We probably had 4 or 5 transferred post delivery, but one I remember very well who ended up needing a transplant, who got into problems around about three days post delivery with her crisis. So I think you have to, in the sort of rush to kind of get the patient off the delivery ward, if that's your safest place for observation, or if they're not on HDU, they really do have to be closely monitored. And help. I'll just get through this because we've just slightly pushed for time. About just under 1 in 100 pregnancies. Pretty, I think it's a bit rarer than that in my own experience. Again, similar sort of time frame. Symptoms, epigastric pain. Again, that's a symptom that's not very helpful. I would say that most women, certainly in the third trimester, will get a degree of acid reflux, or a lot of them will. So I'm not sure that is very helpful. The hypertension and the peripheral edema, I think has to be an alarm bell. And the one thing that we do well is dip urine. I think that seems to be quite consistently done well. I think you have to think about this as being a sort of microangiopathic state. So their D dimers are usually positive, the platelets fall, and they look like essentially like like DIC. This condition, I think, as I say, it's a pregnancy associated condition or effect on the liver, but I think you have to think about this in terms of the effect on the kidney function, the heart, cardiac muscle function as well. And I've certainly seen patients with HELP with profound cardiac failure, and of course then you get into the spiral of the effect on renal dysfunction, ischemic renal and hepatic necrosis as well. So it's a condition that once, if it's not recognized and recognized early, and even when recognized, it can spiral very quickly into multi-organ failure, with poor outcomes for both mum and babe, obviously. So I must say, these days I tend to think of these acquired liver diseases in pregnancy more as this sort of spectrum of disorders. I think pruritus is pretty common. Nausea and vomiting is common. When women, when headaches, I think less so, and probably confusion certainly less so. And then these sort of physical signs, peripheral edema. Well, that's not uncommon in women towards the end of pregnancy, so not necessarily that specific. And then these tests. I've drawn this up so because as I was thinking through what I consider to be normal, and what are the kind of things that point me in one direction or another. I think these days, when I'm asked to see a patient who's got abnormal LFTs, who's in pregnancy, I must say I tend to think of this as these as being a sort of, I think more of it as being this soup of disorders, and try and think about how they might have one aspect, perhaps a higher ALT, or might push me in one direction or another, or the platelet count, or whatever, the clotting. So that's the sort of way I think about these. I'm just going to share a couple of patients with you, just because I am running out of time, and I know that you might want to ask some questions. So this is a lady we had very recently, 32-year-old. Her first pregnancy was with IVF, with no problems at all. And the second pregnancy, she has twins, and she presents at 28 weeks with enough symptoms, although they were vague, and she was a lovely lady, very, very capable of giving a good account for herself, but she had some very vague symptoms. Her blood pressure was up a little bit, and a liver function test was done. Now, if we were in a room, I might then ask people to put a hand up and say, are there any other questions that you might like to know the answer to? But as we're here, I'm going to tell you that one of the things that was difficult not to notice was that she was quite, perhaps a bit overweight, and probably had a BMI of 30-31. So when the ALT initially of 64 was given to me, the first thing I did was to go back and see when her previous LFTs had been done, and she had not had an LFT for about 4 or 5 years that I could find. So an ALT in someone who's overweight of 64 didn't necessarily cause me much concern, but the one a week later was perhaps more focusing. So at that point, we instituted, I went through a history with her. I checked all her medication. She'd not been taking toenail yak or anything like that. And we carried on monitoring, and a week later, that happened. So at this point, again, she was well, her blood pressure was up a bit, and we started thinking at 30 weeks about what the possible outcome might be. Now, she had one of your sizing scans, and the babies, I think, were about 1.5 kilos each, or something of that order, 1.3 and 1.6 or something, I don't know. So not massive, but not particularly tiny, I was assured. That seemed pretty small to me. And then about 3 or 4 days later, the ALT leapt, and I remember the speaking to the lady who again was very well and actually was not absolutely sure about what all the fuss was about, but she ended up being delivered shortly afterwards, and both mum and the twins have done well. So I think not very many symptoms. I think for my money, probably acute fatty liver of pregnancy. Would I have ultrasound scanned her? Well, we did do an ultrasound scan, and it did show fatty liver, but I don't know what that means in this circumstance, and in that I don't think that will go away. And then just one other case very quickly, was just to remind me to be careful what I wish for. This was a lady, or is a lady of 37 years old, and I know one or two of the people in the audience might be familiar with this case. But at 37, after a colourful life, if I'm allowed to call it that, of a lot of drugs and a lot of alcohol, she presented with acute alcoholic hepatitis, and if you look at the down here at the numbers, she was profoundly jaundiced, profoundly coagulopathic, and profoundly hypoalbuminemic. So profound synthetic failure, basically liver failure, with an in-hospital mortality, even in a 37-year-old woman, of about probably 25-30%. So not great. And she told me that she was going to stop drinking, and I must say I didn't necessarily take a great deal of notice. But 3 months later, she presented with an acute variceal bleed and survived. And actually, her liver function had improved, which did attest to her claim. We put her on a variceal banding program, but then the virus came along and scuppered all our good wishes and good hopes. And then in October, and it was near November when the letter came, our GP wrote and said, "Oh, by the way, Nicola is pregnant." And so we arranged to see her rapidly, which after the next lockdown turned out to be in early February. And at that point, these were her blood tests. Just a reminder. So she had a variceal bleed, and just to put this into context, in the context of variceal bleeding in pregnancy and delivery, that carries with it, if those, and you can see these little red patches here, those are signs of potential bleeding points, and that carries with it around about a 50% mortality risk if they bleed in these circumstances. So with some excellent help from colleagues, well, first of all, we obliterated her varices. I'm going to finish this quickly because there might be some questions. And that's what those varices now look like. So you can see these things here, which are the big chunky varices, are now here. That's a scar from a varix. There's probably a little remnant varix there, but it's tiny by comparison. And there's one up there. So we obliterated the varices, which immediately reduces down her risk of bleeding. Of course, the risk that pressure just goes a little bit further down the road, if you like. But in terms of risk of bleeding, that's the main source of bleeding. And we await the next bit of the adventure with Nicola with interest, because she's not quite made it to the delivery room yet. Anyway, she has continued to be abstinent, and she is no longer in liver failure, so that's good. So obesity and alcohol, don't forget, common and frequently alter ALT. You know, I'm in two minds as to whether I should be thinking about recommending liver function tests as a baseline for women who come to who do get pregnant, in the sense that it allows you then to compare that first ALT that you get of 60 or 70. The symptoms, the signs are all there. Acute fatty liver is a spectrum. So I think early delivery and then remain vigilant, and that's my message. That's my talk. And don't forget about hepatitis E, CMV, gallstones, that can occur, as well as all these other nasty things that we tend to worry about. Okay, I'm not sure what I'm supposed to do now, so await questions.
Thank you, Dr. Milson. That was really, really an interesting talk. Liver disease in pregnancy is obviously a very challenging issue, and experts like you are of great help. So I'm going to hand over to Dr. Vishal Pai. Vishal is a YSOA trainee representative, and he's going to be moderating the question answer session. I think we have a time for one question, Vishal.
Yeah.
Thank you.
Thank you so much, Anju. Thank you, Charlie. That was a very interesting talk. And like you said, with the increase in incidence of obesity and alcoholism, liver issues are only on the rise in the country, isn't it? Unfortunately, there were no questions from many of our delegates. I couldn't pick up any from the chat box, but we have come with one question for you, if you could quickly answer that for us. Do you think that liver diseases in pregnant women who develop during their antenatal period, do you think there is any chance that they can progress towards chronic liver problems later on? And if in case they do develop, are there any lifestyle modifications, as any statist we can advise our patients how they can improve on their lifestyle and
I mean, a third of our adults are overweight. We reckon that, and of that third, if you do the maths, obviously half of those adults are women, and around about 2 to 5% of those patients will go on to develop chronic liver disease, cirrhosis, and need either liver transplantation or will die of chronic liver disease. And our big problem at the moment is trying to identify that group of that well group of patients, because that they are well, they have no other symptoms, and try and get a pointer towards an investigation. And because 100% of them will have fatty liver disease. It's just whether they're in the unlucky 2 to 5% who are going to go on and get cirrhosis. So I would say that the advantage of seeing well people, and the bit that, you know, where I would kind of bang the liver drum, is asking them about alcohol and their normal alcohol intake, and asking them about or pointing out the risks of obesity as they get older, and not least the risk, you know, the likelihood of their children growing up to be obese as well, obviously much higher in that population. So it has massive public health implications. So it's more I would say a public health issue, really, because for most chronic liver disease does not allow you support pregnancy. So for Tracy, the lady that case report, there was no way that she would, the very fact she got pregnant supported her claim that she'd become abstinent. That's why I say you have to be careful what you wish for in this life, because if she'd carried on drinking, there's no way that pregnancy would have gone anywhere close to as far as it's got, because there's such a demand, physiological demand. So yeah, these people are well, and because pregnancy effectively wheedles out those with poor liver function. But once they're well enough to get that doesn't preclude them from getting liver disease later on in life. So I think it's a public health message, really.
Well, thank you so much.
Right, pleasure.
Handing it over back to Dr. Anju.
Thank you, Vishal, and thank you, Dr. Milson.
I mean, a third of our adults are overweight. We reckon that, and of that third, if you do the maths, obviously half of those adults are women, and around about 2 to 5% of those patients will go on to develop chronic liver disease, cirrhosis, and need either liver transplantation or will die of chronic liver disease. And our big problem at the moment is trying to identify that group of that well group of patients, because that they are well, they have no other symptoms, and try and get a pointer towards an investigation. And because 100% of them will have fatty liver disease. It's just whether they're in the unlucky 2 to 5% who are going to go on and get cirrhosis. So I would say that the advantage of seeing well people, and the bit that, where I would kind of bang the liver drum, is asking them about alcohol and their normal alcohol intake, and asking them about or pointing out the risks of obesity as they get older, and not least the risk, the likelihood of their children growing up to be obese as well, obviously much higher in that population. So it has massive public health implications. So it's more I would say, a public health issue, really, because for most chronic liver disease does not allow you to support pregnancy. So for Tracy, the lady that case report, there was no way that she would, the very fact she got pregnant supported her claim that she'd become abstinent. That's why I say you have to be careful what you wish for in this life, because if she'd carried on drinking, there's no way that pregnancy would have gone anywhere close to as far as it's got, because there's such a demand, physiological demand. So yeah, these people are well, and because pregnancy effectively wheedles out those with poor liver function. But once they're well enough to get that doesn't preclude them from getting liver disease later on in life. So I think it's a public health message, really.
Well, thank you so much.
Right, pleasure.
So our next speaker is Dr. Matthew Bellardi. With the great pleasure, I introduce Dr. Matthew Bellardi, who is a consultant imaging cardiologist with special interest in heart disease and pregnancy, echocardiography, cardiac CT, and nuclear cardiology. He completed his cardiology training in Leeds at the LGI. It was here that he found his calling when attending the combined obstetric clinics and adult congenital clinics, treating patients with both congenital and acquired heart disease in pregnancy. He's also the treasurer of the British Nuclear Cardiology Society at national level and regionally, a cross-trust cardiologist who has built strong links across the region, improving the care of patients with heart disease in pregnancy, congenital heart disease, and inherited cardiac conditions. More locally, Dr. Bellardi has started and supported cardiac imaging services, specifically improving the care of patients with heart valve disease. And he's going to talk on management of cardiac disease in pregnancy in units without specialist obstetric cardiac services. Over to you, Matt. Thank you.
Hi, everybody. Can everybody see the slides and hear me?
We can hear you and we can
Perfect.
See your slides.
Excellent.
Thank you.
Thank you very much for that lovely introduction. And thank you for inviting me to present. I spent some time thinking about this and wanted to sort of convey that heart disease in pregnancy isn't quite as scary as we all think, and we can do quite a lot in our own units, and we don't have to send everybody across to sort of specialist centres, although there is clearly a role for them. So I believe that women, families and children deserve more from what we give them, and I'll explain why I believe that in the next few slides, hopefully. So what's the difference from the outset between cardiac obstetric units and where the majority of us actually work? Well, obstetric units are co-located. Cardiology, cardiothoracic theatres, cardiothoracic anaesthetists, labour ward, the obstetricians, obstetric anaesthetists, and so on. So within our sort of friendly hospital boxes, we've got our patient, which then presents to all of these services that we're all familiar with and know and love. And for the cardiac obstetric unit, they're all in one place. Whereas, for example, for Hull, they're in two places. And the patient is divided between those two services. Now, I'm not saying that that's necessarily inferior, and it's what we have at the minute, but I think this is where sort of the problems arise and communication issues happen. So why are deaths continuing to increase? We've heard lots about reports from Mr. Phillips, and we're all familiar with Embrace. And actually, the deaths aren't quite increasing, but they're at least levelling off, and we're not winning. So why is that happening? Can we also say that we're providing the best experience for these ladies and their families? Some of you will have thought, well, yes, we're awesome, we're amazing, and yes, we're very good. But is there really no room for improvement? And I think there is. I think there's great room for improvement. So this is the Embrace report of 2012 to 14, and I think we're all familiar with this. 8.5 women per 100,000 died. And 2 of those 8.5 were due to heart disease. And I believe this was the first time that heart disease was shown to be the most important cause of maternal mortality, and services haven't quite reflected that data so far. Again, this is 2012 to 2014, and the death rate seems to be plateauing off. What are these women dying of? Well, we used to think it was thrombosis and thromboembolism, but that's sort of halfway down the pile. Dr. Odor discussed anaesthesia, which is right down the bottom. Preeclampsia is another sort of high-risk feature that we've talked about, but cardiac disease is right up near the top. So this is sort of more recent data from Embrace, again, from 2015 to 2017, and overall 209 women died amongst 2 million plus, 2.2 million plus births in the UK, which equates to about 9.2 per 100,000. So we haven't got better. It was 8.5, remember, from the previous sort of 12 to 14 data, so 9.2 now, and still heart disease is right at the top, 23% of those women, which equates to 2.1 per 100,000. So 0.1 increase per 100,000. It sounds like small beans, but that's a group of people that are dead because we haven't quite got it right yet. This is slightly more up-to-date data, so 16-18, numbers still going up, 9.7 women per 100,000 now, and still cardiac disease is right at the top. There's a few other things in this report about stroke and epilepsy, but ultimately cardiac disease in pregnancy remains at the top, and the numbers are going up. This 16-18 report discussed systemic biases, which is a hot topic across our culture currently, and heart disease in pregnancy is not immune to that issue. They believed that it was preventing women with complex problems getting the care that they required, and I don't disagree in some circumstances. So if we break down the causes of cardiac death, you can see at the top sudden adult death syndrome, and the MNH is morphologically normal heart. So this is a group of patients actually that's really hard to find, and the first presentation by definition is sudden death. So it's a really sad situation. pregnancy is overrepresented in this group of individuals, probably because of the increased physiological demand on masking various other conditions such as arrhythmia, 22% ischemia, which is quite alarming, 18% myocardial disease, 14% aortic dissection, 7% valve disease, and only 5% pulmonary hypertension. Right at the bottom is 7% congenital heart disease, which can obviously be involved in any of the other categories, which is why that grey-blue dot is in the middle rather than representing a slice of the pie. More recently, has anything changed or got better? Well, interestingly, and I don't know why this is, if I flip you back to this slide here, 31% of sudden adult death of morphologically normal heart, and now it's only 18%. However, everything else has gone up. So myocardial disease from 18 to 27%, ischemic deaths from 22 to 24%, and so on. So overall, we haven't got better. We're sort of shifting the focus, really, and it may represent the fact that we're actually looking after some of these women better and taking more women through higher risk pregnancies, perhaps. So some epidemiology. I'm sure you're all familiar with this, but we'll run through it. So 0.2 to 4% of pregnancy are complicated by cardiovascular disease in developed countries. And I think the variation in that number represents different regions across the developed countries. They're increasingly risky patients, partly because of successful treatment for congenital heart disease. So there are now more adults than children with congenital heart disease that are alive. And that's sort of the aim of congenital heart disease treatment. More of these ladies are reaching childbearing age. And in addition to that, as a society and a culture, our cardiovascular risks are increasing, maternal age is increasing, and prevalence of hypertension, obesity, and diabetes are also increasing, which we've heard in other talks today, add to your risk in pregnancy. In the developed countries, 3/4 of heart disease in pregnancy is accounted for by congenital heart disease. And it's generally rheumatic disease in developing regions that causes the problem from a heart point of view. In terms of risk assessment, the World Health Organization is a nice, easy risk assessment to apply. So WHO1 would be no detectable increased risk of mortality. WHO2 is a small increased risk of mortality and increased morbidity. WHO3, significant increased morbidity and mortality, and expert counselling is generally required. If people decide who are classed as WHO3 to continue in the pregnancy, they should really be going to specialist obstetric units to plan labour, delivery, and the early postpartum period. WHO4 really shouldn't be getting pregnant from risks of maternal and fetal mortality. However, if they decide to continue the pregnancy, we manage them as WHO3. Problem with this model is it's pretty vague. It doesn't give you any specific recommendations as to how to categorise these ladies, but we'll hopefully go into some of that later on. Once we've identified ladies who are in these risk classifications, what do we do with them, or what should we do with them? So the ROPAC data from the Ross Hesselink and her group in the Netherlands published some time ago now, and they quite helpfully produced this table where you can see that the risk of maternal mortality jumps after WHO2 into WHO3 and then WHO4. Absolute mortality isn't especially high, 4% mortality compared to Charlie Milsom's 50% mortality with varices. It's not the same ballpark, but it certainly is a sort of tenfold increase from WHO1, for example. So I think these ladies need counselling very carefully as to how they proceed. Similarly, if you say to someone who's WHO3 they've got a 3 times chance of dying, that doesn't necessarily mean very much to them, but if you tell them sort of the chances of death are fairly small, but then hospitalization is a 1 in 3 chance, for example, 36%, compared to a 10% chance of who won, that might mean something slightly more to them. With the cardiac side stripped out, chance of heart failure again jumps, so you're 4 times more likely in WHO 3 than in WHO 2 to develop heart failure. And indeed, you're significantly more likely to have both supraventricular and ventricular arrhythmias in both WHO 3 and WHO 4. Equally, don't forget the postpartum period. So those with heart failure at different gestations who presented in pregnancy and early postpartum period, the vast majority of patients presented in the postpartum period. And we'll go through some reasons why that might be. So you've got your risk assessment, so what do you do with it? This slide was partly borrowed, and so I've changed it. It used to say all patients with congenital heart disease should have pre-pregnancy counselling, but I believe that all patients with cardiovascular disease should have pre-pregnancy counselling to discuss their risks of both, hopefully, pre-pregnancy and not post-pregnancy is where we usually get them, but to discuss the risks of pregnancy and what that might mean, and particularly tell them to stop taking certain pills. Again, if it's not happened, we should engage the specialist centre or the cardiac obstetric centre and have an MDT discussion. What we tend to do more locally now is to have a local MDT discussion, and if we get stuck, or if we're not getting the outcome that we feel might be required, we'll get specialist advice from the team, but locally would be Leeds for us. There's a number of simple conditions that can be treated almost normally in the majority of centres, and we do have a high number of sort of significant LV dysfunctions or arrhythmic type patients coming through our centre. Even simple conditions, however, don't be fooled. We still need to perform careful assessment of both the patient, the cardiac and the obstetric related risks. And even some moderate lesions, depending on what they might be, can be treated in the local centres with more individualised care plans. But if in doubt, seek advice. So what's normal? Well, these are supposed to be the lowest risk patients, aren't they? Is normal someone that doesn't require specialist input antenatally? Is it someone who's safe to deliver in a non-specialist unit? Is it someone who's safe to deliver in a midwifery-led unit? Is it someone who's safe to have a home birth? I would probably say yes to that one. Generally, what we would say is it would be someone that's safe to deliver in a local obstetric unit that does not require specialist follow-up. So, for example, ongoing cardiac issues that would require follow-up. This can present a problem, however, because in normal pregnancy, what we know is that most of them are tired and breathless. And this is because of increased cardiac output, increased oxygen uptake, increased minute ventilations and tidal volumes, reduced respiratory reserves, etc. Up to 80% will have peripheral edema, and that gradually progresses throughout the 3rd trimester. And 90% of ladies will have ejection systolic murmur. So we're looking for a needle in a haystack, or as I prefer to call it, a needle in a needle stack. This can be quite hard to discern, particularly when you receive paper referrals saying this lady has a murmur, please see. But we must remember where we started, and we have to try and challenge our systemic biases. So just because 90% of ladies have a murmur doesn't mean that there isn't a problem. And I tend to run an open door policy for most of these people as resources allow. So we've done the sort of normal or presumed no risk. Which conditions are low risk? I would have to say that none are no risk, but normal cardiac physiology, low risk, yep. Normal cardiac function, even with some operated or healed lesions. No more than mild valve disease, although be careful with mild mitral stenosis as it reduces your cardiac output. Minimal shunts, they should be classed as low risk, particularly at the atrial level. Normal systemic and venous pressures. Normal great vessel dimensions. No concerning family history, for example, of aortic dissection or sudden adult death syndrome, or indeed of any other inherited cardiac disease. And those with no symptoms. A lot of patients assume will come through the cardiac unit and assume that they have to have a cesarean section or that it's mandated. And this was an article, again, powered by the ROPAC investigators, that was quite useful. And they concluded that that planned cesarean section didn't confer any advantage over planned vaginal delivery. Just they looked at planned vaginal delivery, not so much spontaneous vaginal delivery, but we can talk through the merits of either. It didn't have any benefit in terms of maternal outcome, and planned cesarean section led to adverse fetal outcomes, or an increase of adverse fetal outcomes, I should say. So from that paper, we're probably doing something right, at least from that data. Selective cesarean section powered by WHO risk assessment and clinical experience in experts minimized morbidity and mortality in those highest risk patients. ROPAC does support this view, and I do appreciate it's only registry data, but as Dr. Odell said, it's quite hard to get randomized trials, or indeed any trials, up and running in pregnancy. Level of care can be replicated in women requiring grade 1 and 2 cesarean section out of hours. I put that in italics because I'm not really sure that we're resourced for that, but we can talk about that. And as such, we should continue to exercise our judgment when counselling women on their mode of delivery. Overall, generally, we should say that WHO 1 and 2 vaginal delivery is the safe first choice. And for WHO 3 and 4, this should be judged on a case-by-case basis. So vaginal delivery is generally preferred, less blood loss, lower risk of infection, and venous thrombosis. Cesarean section is reserved for obstetric reasons, so I'm looking at this from a cardiac point of view, but we can consider it in women on oral anticoagulation preterm labour. Now, those with Marfan's and aortic diameter of greater than 40 millimetres, it's sort of risks are directly proportional to the size of your aorta. So less than 40 millimetres, we don't tend to be too worried. Over 40 millimetres, however, we do get these sort of relatively large, we get these large relative jumps, fairly small absolute jumps in mortality under 50 millimetres. So in local centres, however, I haven't recommended that any of these ladies try and push during labour, though. Acute or chronic dissection, well, again, I don't think that we should be really considering getting baby out by that stage. Intractable heart failure, equally, I don't feel that they should be having planned vaginal deliveries. Mechanical valves, yes, they can do, although it's management of the anticoagulation that becomes very hard. And severe outflow obstruction, pulmonary hypertension, and isomega syndrome, we can't make any general rules for that population. At the European registry, the caesarean rate was 41% over the normal population, however, it should be noted. So they had a higher caesarean section rate, so perhaps that's where they maybe had slightly worse fetal outcomes. So in vaginal delivery, epidural is often recommended, reduces pain, sympathetic activation, and a reduced urge to push. Hypotension can be an issue, however, so beware of obstructive lesions and particularly cyanosis. Labour in the lateral decubitus position can minimise the hemodynamic effects of uterine contractions, particularly on venous return. Head to perineum without pushing to avoid unwanted effects of Valsalva, so your passive second stage. And these ladies may need assistance with forceps or vacuum extraction. Again, don't forget the physiological changes directly after pregnancy, so autotransfusion is felt to deliver a rapid bolus of 500 mils of fluid. So this is partly powered by this presentation with heart failure is partly powered by that process. Postpartum, you can probably tell me about this more than I can tell you, but oxytocin's used to prevent hemorrhage. Give it slowly to prevent systemic hypotension. Again, beware of obstructive lesions. Prostaglandin F analogues, useful for postpartum hemorrhage. You have concerns regarding pulmonary hypertension. And try to avoid ergometrin leading to vasoconstriction and hypertension. My experience is that meticulous leg care happens anyway, with TED stockings, early ambulation leading to reduced thrombotic risk. And we would recommend these ladies have hemodynamic monitoring for about up to 48 hours, sometimes more, depending on their LV function, in case that causes an issue in the early postpartum period. So, on to the cases. This was a young lady, 37-year-old, presenting at 12 weeks in her third pregnancy. She was diagnosed in January 2016 with a dilated cardiomyopathy and severe left ventricular systolic dysfunction of uncertain cause. Pre-pregnancy, she was NYHA 2 to 3, which is breathless on moderate to minimal exertion. She was on optimal medical therapy and had a CRT-P pacemaker, cardiac resynchronization pacemaker in situ. So she's pretty top whack of therapy for heart failure. And prior to the referral, so when she pitched up in pregnancy, her ACE inhibitor and her spironolactone, her MRA, was stopped. She unfortunately continued to smoke. So this was her ECG at presentation, and for her, this is actually a normal ECG. So many of you will be staring agog at the broad complexes and all the spikes all over the place. It's equally a right bundle branch block, so you wouldn't expect that with a pacemaker. However, this is a predominantly left system, so she's pacing the left system, which creates the left bundle branch block, and it's broad, which is okay, although ideally it would be nice if it narrowed off when we paced her. Beggars can't be choosers. So for those of you who haven't seen much echocardiography, I hope those videos are playing. I can certainly see them here. This is a normal ventricle, a normal 4-chamber view. So at the top of the screen, you have the sort of pointy bit of the heart at the top, and then the two collecting chambers, the atria at the bottom. And then this is the 2-chamber view taken at 90 degrees to that view. So this is a slide I've used elsewhere, but it highlights the potential issues that she could be having. So the top 2 pictures illustrate a pericardial effusion, where there's rocking of the entire heart, and there's the movement of the right atrium looks slightly odd. Equally, with the volume loading in pregnancy, patients can develop mitral regurgitation, which is that colour flow, that big blue plume of colour coming through that mitral valve there into a sort of dilated left atrium. And indeed, the bottom right picture shows LV dysfunction, so that the top half of the left ventricle just isn't really working at all. So all of these could be the consequence of this poor lady. Let's say we don't get good views. Contrast echocardiography is pretty safe in pregnancy, and should we be unsure of the ventricular function, given what I've told you about its prognostic value and risk stratifying these ladies, we can use contrast echo should we need to. We've now got special equipment that does contrastless contrast, which does sound a bit odd, but what the technology allows us to track blood cells and produces an image very similar to this. I unfortunately wasn't able to get one for today's presentation, but it looks similar, meaning that we don't need to inject anything into anybody now to get better pictures. Equally, if we're unsure about valve disease, we can perform 3D echo, and this isn't transesophageal, this is transthoracic imaging. So things have perhaps come on leaps and bounds from when people have last seen this sort of thing. Images on the left are of just standard 2D imaging, and on the right a colour flow mapping of the same hole within that mitral valve. Equally, if we can't get good 2D pictures to assess the function, we can do things quantitatively with tissue Doppler. And so many of our ladies where the LV function's in doubt, we can perform longitudinal strain or indeed global strain to produce this heat map to tell us what's normal and what might be abnormal. Again, helping with risk stratification and prognosis. So how many are feeling like that? Or are just curious, or sweating, or maybe a little sick? Well, this girl kind of did that for everybody. So how did we manage her? She was seen in MDT on 2 occasions, and we recommended termination to start with. Her ovary function was terrible, and we had to stop much of her medical therapy. The lady did decide to continue pregnancy, as they tend to do. So how do we manage heart failure in pregnancy? This is a sort of complicated slide for a reason. These are all the trials from 1985 up to sort of 2014, giving us the evidence map for how we treat heart failure. And you can see the sort of large evidence base and all the different various therapies that we can use we can use for those patients in heart failure. This is what we can use in pregnancy. So we're quite limited. You can see there is evidence for carvedolols, digoxin, hydralazine and nitrates, and her CRT device, but all the other stuff we just can't use. So she did really well. She was reviewed on the day ward and delivered, and then she was slightly horrified that we told her that she wasn't out of the woods yet. As she stated, she'd got through the risky bit. And indeed, cardiac output rises during labour and delivery, but 1 hour postpartum, it falls quite rapidly. And again, I'll remind you of this slide here. Reassuringly, she did fine without too much medical therapy. And we restarted things for her pretty sharpish. So this second case is borrowed from my colleagues in Sheffield, Bateson Centre. And this was a lady who is British Asian, family history of angina in her mother in her 40s, father in her 50s, but no affected siblings. She was on the larger side of life. And in February 2008, aged 28, she saw cardiologist A during her first pregnancy with atypical chest pain. She went on to have an exercise test, which was a false positive, and had an uncomplicated normal vaginal delivery. In 2008 to 2014, she had further uncomplicated pregnancies with normal deliveries. And in 2015, age 35, she saw cardiologist B, again with some more atypical chest pain. Cardiologist B arranged a CT coronary angiogram, but the patient didn't come. So in August 16, now age 36, she sees a third cardiologist 6 weeks into her 4th pregnancy. She'd had 2 miscarriages in the interim, and now she's getting exertional chest pain. So she was referred to Sheffield's local heart disease and pregnancy specialist, cardiologist D. In October 16, she was fatter than she was before, and there's now this sort of question mark as to whether this exertional chest pain is now ischemic pain. Again, she had an exercise test with chest pain within 3 minutes, so early chest pain and minor ST changes. Her transthoracic echo, however, still looked normal, and she was already taking aspirin and intermittent GTN. A month later, she saw another cardiologist who wasn't cardiologist D, but also by luck was a heart disease and pregnancy expert. So by this point in November 16, she was getting daily exertional chest pain. She was troponin negative, and they admitted her for planned titration of medication, primarily beta blockers, and to do a CT coronary angiogram. However, the patient didn't come. So in January 17, at 30 weeks into this pregnancy, we finally got hold of her, and she had an invasive coronary angiogram by yet another cardiologist. Most of us who do heart disease in pregnancy don't tend to be invasive types, although there are exceptions to every rule. And this was her angiogram. So for those of you unfamiliar, I've labelled the left and right coronary arteries, and you can largely ignore the words as there's many 3-letter abbreviations, but you can see by the yellow circles, those are parts of the artery that are particularly abnormal. So the distal disease is pretty severe, and that proximal circumflex disease, just highlighted by the last circle, is also important. That disease further on will also be causing us symptoms. The last circle that appeared there was the left anterior descending artery, which is usually the one that's most prognostically important. So she's got disease in all three vessels and fairly important branch vessels. Ischemic symptoms in younger women. So I'm sure you're all aware of the discrepancy between men and women presenting with all medical conditions, but there was a nice paper here looking at the sex characteristics in early diagnosis. Generally, discomfort develops over a few minutes. It rarely is in the anterior chest for ladies, often in the epigastric area up to the neck. They generally get more jaw pain, arm and shoulder pain. They don't tend to sort of describe a typical sort of squeezing retrosternal type chest discomfort. They get more features of breathlessness, and that may indeed be the only presenting feature. So quite hard to pick out from your 30-week pregnant lady who's getting breathless. It's often associated with more gastric type symptoms, so nausea and sweating, and can even be associated with syncope. So in conclusion, ischemic pain, well, for this case anyway, ischemic pain is often overlooked, as often atypical, and that goes for all women, not just pregnant women. Risk factor profiling doesn't work for these people and harms young, both women and men, disproportionately. Only 60% of the non-pregnant patients with symptoms suggestive of angina have coronary disease. And I wouldn't shy away from invasive coronary angiography should it be indicated. Certainly CT, if they turn up, is almost equally as good in terms of prognostication. But remember, we can't treat people through a CT, but we can do through an angiogram should it be required. Most treatment for stable angina and coronary disease can be used in pregnancy, with the exception of statins and ACE inhibitors. And familial hypercholesterolemia remains low compared to the known prevalence. So those patients with a sort of the incidence in the general population is a sort of 1 in 500, and yet we see very, very few of those patients. I'd like to acknowledge all the people I stole shamelessly from. Thank you for listening.
Thank you, Dr. Beladi, for such an enlightening talk. I think you have covered all the key points on how to manage these patients where we don't have specialist cardiac services on site. So without any further delay, I'm going to hand over to Vishal because I'm sure there will be a couple of questions for you to answer, please. Thank you, Vishal.
Right. Thank you, Anju. Thank you, Matthew, for that wonderful talk. Well, there were two questions that were raised in the Q&A box, both by Dr. Jayakumar. The first one reads, is there any role of doing echo in patients who present with these murmurs? What do you think is the role of doing an echo in such patients for preoperative scanning, whatever?
Yeah, that's a good question. There is a role of doing an echo. I think there's probably more of a role of a sort of specialist clinical assessment, and I'm not saying anaesthetists aren't specialists at detecting murmurs, but it's more a sort of what's a benign murmur and what's a more sinister murmur. And this is the remit primarily of paediatric cardiologists as well. This is their sort of bread and butter and what they see 90% of their children for. There are well documented criteria for looking for benign murmurs versus significant murmurs. My feeling is again to be all inclusive. So if this is, for example, a new murmur that's never been heard before, or are these people getting other symptoms? So are they breathless along with this murmur? Are they getting leg swelling outside of what might be considered normal for pregnancy? So we usually talk about sort of 2 flights of stairs that they can manage without stopping. Is their edema progressive? Is their breathlessness exclusively on exertion, or is it indeed happening at rest intermittently? Do they have other features such as palpitation? So I'd recommend a sort of more holistic type thing. Important murmurs to rule out. Obviously, regurgitant murmurs are quite well tolerated in pregnancy, even the severe ones. It's the sort of outflow obstructions that we want to be aware of because they limit your cardiac output. So aortic stenosis, pulmonary stenosis, less so. But things like a narrow pulse pressure, is the pulse abnormal? I know these things are quite hard to pick out, but that's why I'm here as a cardiologist. So short answer, yes, echo has great utility. And for me, I'm quite inclusive, so you'll rarely get me saying no to an echo.
All right, and there are two more questions now. I'll tell them both together. Probably you'll have a single answer. When do we need to get cardiologists involved in patients who have postpartum cardiomyopathy? That is one of them. And the other one is, what kind of investigation plan would you suggest in NYHA class 2 patients presenting for the first time in second trimester? So investigations in the second trimester, and when do we get cardiologists involved?
So NYHA2, second trimester, and then when do cardiologists get involved? Okay, so I think this is the crux of the problem, isn't it? When get a cardiologist involved whenever you feel you want a cardiologist, is my opinion. So this is why we probably why cardiac disease is the biggest sort of killer in pregnancy, is that there's this fear of engaging cardiologists, and that will say, go away, this is nonsense. And yes, I will admit this is part of the systemic bias. All women are breathless, all women get palpitations in pregnancy, but it's the looking for those needles in the needle stack, or the needle in the haystack, whichever euphemism you want to use. So if you're at all concerned, I'd get a cardiologist involved. NYHA2, so sort of breathlessness on moderate exertion that limits activity a little bit in second trimester. So it's still pretty early. I think my rule of thumb is if they can climb a flight of stairs, if it's gradual, so progressing over weeks, there's no sudden deterioration, no sudden change, and for example, their ECG is normal, that's all really useful. A key blood test that I haven't mentioned actually is the BNP. So BNP doesn't really go up in pregnancy. So if you're at all worried, take a BNP blood test, and if it's normal, that's very, very reassuring. If it's mildly elevated, we can then have a chat about it. But generally, sort of a BNP over 100, we should be seeing these patients because they might come a cropper. Most of the people, so those with sort of even mild LV dysfunction, I'll see on a monthly basis in pregnancy. Those with anything more than mild, I'll tend to bring on a 2-weekly basis, depending on how they are. If it's their first pregnancy, some of them I'll see weekly. Resources and issues with appointing and admin tasks notwithstanding, but that would be my aim. So I'm keen to be heavily involved with these people. Some of my cardiologist friends may shoot me.
Right. Thank you so much, Dr. Matthew. I'll be giving it over to Anju now.
Thank you, Vishal, and thank you, Matt. Thank you to all the speakers for this morning session.
We're going to start with the trainee presentations, which is always a very pleasant session. And first of all, I want to introduce Dr. Nick Mail.
My name's Nick Mail. I'm one of the specialty doctors in anaesthetics working in York Hospital, and I'm just going to briefly discuss a recent case that we had here in York of a lady who presented with a new diagnosis of thrombotic thrombocytopenic purpura postpartum. So TTP is a rare life-threatening haematological disorder that can sometimes be triggered by pregnancy. It's a condition that requires extremely quick diagnosis and specialist management, as there's a very high mortality of up to 90% if it's untreated. There's also a high fetal mortality associated if it does present earlier on in pregnancy. So the clinical presentation is a picture of thrombocytopenia with microvascular thrombosis and hemolysis. TTP can either be congenital or acquired, and the diagnosis is made by ADAM-TS13 activity, less than 10% of normal, and also looking at for either the presence or absence of anti-ADAM-TS13 IgG, which helps to determine whether it is congenital or acquired. So the normal function of ADAM-TS13 is to cleave von Willebrand factor into smaller parts. So if there's a deficiency of this, it can lead to spontaneous thrombosis intravascularly with shearing of the red blood cells and depletion of platelets, which causes the clinical syndrome that we see. The treatment of TTP is with urgent plasma exchange and immunosuppression. So the case that we encountered recently was of a 33-year-old primoporous lady who presented at 35 weeks. She's got a significant medical history of myasthenia gravis. She attended the labour ward triage with a history of right quadrant pain, headache, peripheral edema. Her notable blood tests were a raised creatinine at 115, ALT at 324, and FOS at 1029. The initial diagnosis was acute fatty liver of pregnancy, which links back nicely with Dr. Milson's talk earlier on. She developed worsening LFTs and renal function, so it was decided that she should have a grade 3 caesarean section the following morning, which was performed uneventfully under a spinal anaesthetic. Post-operatively, her renal function worsened and she became oliguric despite fluid resuscitation, but her liver function did start to improve. At this point, she also had a high blood pressure and had developed a high urinary PCR with falling platelets from 208 preoperatively down to 34. So at this stage, she was treated for HELLP syndrome. The first line treatments can't be used in myasthenia gravis as well as magnesium, so she was started on hydralazine and methyl dopa for her blood pressure control. There was also early input from the haematology, hepatology and the renal teams at this stage. Her platelet count continued to fall, and at a low point it was 8, and she developed a new confusion and forgetfulness. So at this point a diagnosis of TTP was considered. She had blood tests sent off, which later confirmed the TTP with an ADAM-TS level of 4.1 with no detectable antibody, which is suggestive of a congenital cause rather than acquired autoimmune cause. After discussion with the specialist haematology unit in Leeds, it was arranged for her to have urgent plasma exchange delivered while she was still in York due to her instability, and it would be unsafe to transfer her at that point. She was also commenced on methylprednisolone. She had a very good response, thankfully, to the plasma exchange. Her platelet function, her platelet count increased up to 34, and her ADAM-TS level was back in the normal range of 58.2 after 3 rounds of the treatment. She was discharged back to the haematology ward after a total of 7 rounds of plasma exchange, and in the meantime, her baby had been discharged safely home. She had 11 total rounds of treatment and a total hospital stay of 15 days before her discharge. She's got ongoing haematology follow-up and is awaiting genetic testing to determine a possible congenital cause. This was a complicated case because there were a lot of other potential diagnoses that were considered earlier, such as the acute fatty liver of pregnancy and HELLP syndrome, particularly with the high blood pressure and the proteinuria, and they're much more common for pregnant people than TTP, which only has about a 1 in 100,000 incidence. However, because of the severe thrombocytopenia, it's important to consider TTP due to this extremely high mortality for both mother and baby if it's left untreated. There was very early MDT in this case, input throughout this case, which helped come to a timely diagnosis and urgent special management, which ultimately led to a good outcome. Unfortunately, because of the COVID restrictions that are in place at the moment, mother and baby couldn't be together while she was on ICU, but we did arrange extra midwifery and psychological support while she was an inpatient. After a discharge, it's essential to have ongoing follow-up with the haematology team because subsequent pregnancies can be a trigger for relapses of TTP in up to 50% of patients. But generally, with careful planning, monitoring of aromatase S13 levels and replacement as necessary, as well as antithrombotic treatment, the outcomes for future pregnancies are good overall. So thank you for listening. I'm happy to answer any questions.
Thank you very much, Nick, for that very interesting talk. I just wondered, can you tell me a little bit more about the practicalities of providing plasma exchange in a pregnant woman?
So obviously the plasma exchange had to be delivered on ICU rather than the labour ward or the postnatal ward, as you would normally want a pregnant woman to be, or a recently postpartum woman to be. Which did make it difficult for her to visit a baby who'd been admitted to the special care unit. Ultimately, ICU was the right place for the patient because of her extremely low platelet count. At one point, it was down to 6, and she did have quite significant ooze from the vas cath, which needed careful monitoring. It did require a specialist team as well to come over from Leeds Hospital. So they had to come over daily with the machinery and the equipment to deliver the plasma exchange, and a very high volume of donor plasma as well. On her first exchange, I think she needed 27 or 28 units of plasma transfusing.
Okay, thank you. You also mentioned that her lack of antibodies suggested a congenital cause. Is there a way that we can test to see if she has got a congenital abnormality?
So she's currently undergoing genetic testing to see if there is a chromosomal abnormality that could cause TTP. The results weren't back as the last time I checked. They're still being awaited from the specialists' labs, but it's usually with genetic testing.
Okay, thank you very much, Nick.
Thank you.
Next up, we have Dr. Hassan Alwan, who's going to present on uterine inversion after Bakri balloon insertion.
Hello everyone, my name's Hassan. I'm one of the trainees in New York Hospital. So I've just got a case about a uterine inversion after Bakri balloon, and I just thought I'd start off by taking you through my night shift and how the patient presented and what happened afterwards. So I started off the shift, handed over a 36-year-old lady who was para 1, previously fit and healthy, no medical history. During the day, she'd had a vaginal birth, which was complicated by postpartum hemorrhage, initially taken to theatre for an examination under anaesthetic, where she had retained buttocks removed. However, this was further complicated with a major obstetric hemorrhage secondary to atony, and there was a prolonged time without IV access, roughly around 45 minutes. Eventually, a central line was inserted, and throughout that time, blood pressure monitoring was not on. Coagulation was normal, as far as we can tell from the records, and finally the hemorrhage was stopped with a Bakri balloon inserted. At the time, the surgeons were happy with the Bakri balloon because of the tone of the uterus, and they discharged the patient back to the ward. Whilst the patient was on the ward, she developed severe disproportionate abdominal pain, which didn't quite make sense for post-operative pain, and therefore she was reviewed by the consultant obstetrician, and a bedside ultrasound performed by them queried a displayed Bakri balloon. There were some further issues with getting CT due to, again, difficult IV access for the contrast CT, and 4 hours later we eventually got a CT that confirmed the misplacement of the Bakri balloon. The Bakri balloon was actually in the cervical canal, and she was taken back to theatre under a general anaesthetic. Initially, a vaginal approach was attempted but unsuccessful, and this led to the laparotomy and eventually manual traction of the uterus. As you can see from the CT image, the Bakri balloon in the blue arrow is much lower than it should be, and the pink arrow is the fundus where it should be closer to it. In between the balloon and the fundus is a large 9x12 hematoma, which is thought to have decreased the hemodynamic instability that the patient should have had because of a tamponade effect. The patient later on went to HDU for ongoing blood requirements and vasopressor requirements. Just very briefly about uterine inversion, it's a very rare cause of postpartum hemorrhage. The incidence is quite difficult to document, but in a study, a national study in Holland, they found it in 1 in 20,000 with a mortality of up to 41%. It's a very atypical presentation of uterine inversion. Normally it presents in the third stage of labor with severe abdominal pain, a low fundus, and sometimes can present with neurogenic shock due to cervical stimulation. As we mentioned, this lady had laparotomy in the end, but you can also try manual, and ironically, a Bakri balloon is normally the treatment here. Other risk factors include abnormal uterus, connective tissue disorders, and an atonic uterus, which is what we believe this lady had and caused the uterine inversion. And these are just the degrees of uterine inversion. This lady's presentation was probably a first degree uterine inversion. And as you can see, the most severe one is protruding outside of the vagina completely, and the 4th degree. In terms of talking points or discussion points, these are the ones I kind of thought about. So as far as we know, and according to the obstetrician, this is the first case of an inverted uterus following the Bakri balloon insertion. We wondered whether the Bakri balloon and the hematoma above it was actually causing a tamponade effect, and therefore the hemodynamic instability wasn't as profound as we would have expected from a uterine inversion. And this may have caused a delay in the diagnosis initially when the abdominal pain was reviewed. There were about 4 to 6 hours between the initial abdominal pain and then eventually going to theatres. So that obviously was an area of concern. The other thing is, during the resuscitation, this lady had a prolonged time without any access or receiving any blood products. And there's a question about whether intraosseous would have been a good option for her whilst we had no access. The cause is still unclear, but we believe that the ongoing atony for this patient's uterus might have led to the inversion after the Bakri balloon was inserted. So I invite any questions if anyone has any.
Thank you, Hassan. Another interesting case, and sounds like a very busy night shift. So the first question is, insertion of a Bakri balloon is a blind procedure. Are there any recommendations on use of ultrasound to check placement?
I'm unsure about the ultrasound. However, I believe the surgeons were quite happy at the time with the Bakri balloon insertion, because they had the ultrasound afterwards in the room initially to make sure it was fine. And at that time it was fine, but it was when they reviewed the patient for the second time in the labour ward, that's when they thought that it was displaced. So sorry, I can't answer the question directly.
And another question, was it quite late making a diagnosis of uterine inversion using a CT? Should examination, or should we have detected that beforehand?
Yes, this wasn't really the major question and issue, probably in this case. The CT actually didn't pick up any uterine inversion there. The radiologist thought it was retained products in between the balloon and the fundus, and it was only found really when they went into laparotomy by the surgeons. I think the disproportionate abdominal pain with the ongoing bleeding probably should have prompted us to go to theatre rather than spending time trying to get IV access, taking her to CT, etc.
Okay, and then one final question. Sometimes with uterine inversion, you get a parasympathetic activity due to the twisting and the vagal stimulation. Was there any evidence of that in this case?
There was no evidence of parasympathetic activity at all with this patient. She didn't show any signs of bradycardia.
Okay. Thank you, Hassan.
Thank you.
Last but not least, we have Dr. Ahmed Ibrahim, who is presenting on caesarean dilemma in an obstetric patient with transverse myelitis.
Hello, everyone. So my name is Ahmed. I'm one of the registrars that currently work in a Royal Infirmary. I'm just going to present a case report reporting a case about a lady that we had to we encountered last October, who has a history of transverse myelitis, and then looking into the literature and everything, what we have learned from this lady and her condition. So a bit about the patient. She's a 45-year-old lady, primary gravida. It was an IVF pregnancy, presented when she was 38 weeks of gestation with a spontaneous rupture of membrane. Past medical history, apart from 6 years ago, where she presented to York Hospital with symptoms, signs and symptoms of transverse myelitis, and had an MRI that showed a lesion at C4. And then I think she got worked up by the neurologist, and she was a bit of a dilemma. And then they end up diagnosing her as transverse myelitis with concurrent Guillain-Barré syndrome, which is a very rare kind of combination, but it is reported in the literature to happen. So this lady was not referred to an obstetric anaesthetist clinic antenatally, although we did find a paper for referral, but that was not filled and did not reach our anaesthetist at the time. So this lady we did not until she presented to a hospital about in the middle of the night, basically at 2 a.m. So in terms of neurological examination, that was done by two different people. Muscle power and sensory was a bit impaired. It was more noticeable in the upper limbs rather than the lower limbs. So I would say muscle power was an MRC of 4, so a bit of suboptimal response to resistance in her upper limb, and a bit of also suboptimal responses in her resistance in her lower limb as well. Sensation was also impaired, so she couldn't really feel pinprick that much. She reported burning her hands a couple of times without actually knowing. And then she's also hyperreflexic, and when we did some deep tendon reflexes, so it's more of an upper motor neuron lesion, which can go with transverse myelitis. We haven't asked her about autonomic dysreflexia, and we haven't really discussed that with the patient, and she hasn't mentioned it, to be honest, that she hasn't any symptoms of autonomic dysreflexia, which usually happen in paraplegic patients with the chronic spinal cord lesions. And then airway-wise, which was also one of the things that threw us away, is that she was a small lady with a very small mouth, Mallampati-4 with a small theromental distance, so we can anticipate it about 75% to 90% chance of a difficult airway. So that's the patient. So walking through what happened during labor, she requested, after induction with oxytocin, she requested of an epidural to be inserted. At the time, the on-call registrar was not, doing the neurological examination, was not particularly happy to do it themselves, to do an epidural. So they discussed it with the neurologist at the time, who green-lighted it. And then we actually had the consultant to come from home and do the epidural themselves. Again, she was, I think if you see at the poster, we usually give them ropivacaine for epidural analgesia, and this lady had 2 lots of ropivacaine, 20 mils, about 80 minutes different between the insertion and the second top-up, and it wasn't particularly working with her. She was still in pain, she started requesting a bit more analgesia. So the consultant anaesthetist gave her 5 mils of lidocaine about 45 minutes after the second top-up. And that's when her hemodynamic stability started being significant. She got feeling dizzy, and her blood pressure dropped at some point to about 65 systolic. So we gave her some fluids and some ephedrine to actually try and recover that. In the meantime, had the pain, the epidural pain, the labor pain were a bit more controlled, but it was a bit of a bizarre situation. By that time, it was 8 a.m. in the morning, and then they've decided to take her to theatre for failure to progress. So the consultant anaesthetist who saw her at the time had a look into her, assess her airway, and he was thinking about difficult airway in terms if we want to go to GA. Get the epidural at the time initially did not work, was a bit against going for an epidural, a top up, but she was comfortable. She was keen to stay awake and rather than going to sleep. And then before the top up, assessing the level, she was comfortable, but she was able to bend her knees, but can't feel pinprick sensation in the in her chest and in a bit of her chest and a bit of her arms. So again, it was very weird. So we discussed it with her. She's going to be a high risk to be converting to GA if that does not work. But luckily, we gave her adrenaline, lidocaine with adrenaline and 100 mics of fentanyl, and that seems to have kept her comfortable throughout. But as expected, she had a significant drop in her blood pressure at the time, and we had to run a phenylephrine infusion, about 80 micrograms per minute at some points, which is basically running 30 to 60 mils an hour or 40 microgram phenylephrine, which is very high, and giving her double bolus to maintain that blood pressure roughly at an acceptable levels. And then afterwards, baby was delivered, and we had no issues with that. And follow-up, she returned back to baseline with no any residual neurological impairment. So it was a happy ending at the end. A bit about transverse myelitis. It's basically a neurological disorder, inflammation of the spinal cord itself, and then axonal demyelination. The incidence is very rare, so it's about 1 to 5 million per case annually. That's even less in pregnant ladies, and having a combination of Guillain-Barré and transverse myelitis makes it even less of a condition. Again, reported as is, how variable it is in its presentation, its signs and symptoms and complications. The case reports that we had is also very variable, but not more than 10 case reports. They always talk about autonomic dysreflexia, which is an increase in high blood pressure and bradycardia, especially in people with lesion above T6, T7. This lady, if anything, with what we had is basically, had a drop in the blood pressure rather than an increase in a drop of blood pressure from an intervention or urological involvement. So what we would think that would ideal a lady with transverse myelitis, chronic spinal cord lesion, needs to be picked up antenatally, seen by the anaesthetist, had a detailed neurological assessment done at the time, neurological input, and then liaison with the obstetricians and the midwives about plans of delivering her is ideal. Ideal also eliciting IDR, autonomic dysreflexia signs and symptoms, is also of importance, because if these patients had it, then epidural is actually recommended during labor induction for these people. Is at high risk of having an ADR if they previously had it, because we work with the bladder, and then we working with the uterus, and distension of that can stimulate the autonomic nervous system. Vaginal delivery is reported going smoothly in some cases, and then cesarean, we have different ways. It depends on the presentation. So if it's an acute presentation, epidural might not be the ideal option, and then we'll have to go through GA. Again, rocuronium versus oxymethonium depends. If it's an acute presentation, maybe avoid oxymethonium. If it's more than 9 months, then it should be okay, depending on the anaesthetist preference. It does potentially, so transverse myelitis, they do have a prolonged block with rocuronium. It is reported, and then there is a case where it needed to go to ICU until that block's resolves. And then it's reported that sugammadex actually works fine to reverse rocuronium in these patients. So we should be able to reverse that rocuronium with sugammadex as a normal patient. Regional, again, habituals of lidocaine and bupivacaine. If it, as we said, ADR, autonomic dysreflexia, probably regional anesthetic is an option to minimize that incident.
Okay, thank you, Ahmed. That's your time up there.
Okay, yeah, thank you.
Just time for a couple of questions. This lady had Guillain-Barré, which, as you say, is an overlap with transverse myelitis. Were there any special requirements that you needed to make in pregnancy and planning for delivery with Guillain-Barré?
So the issue with her is that she hasn't been picked up at the time. She hasn't been seen by any antenatally. So that was not really, there was no plan. She just rocked up on labor ward when that's the spontaneous structure of membranes, and then we had to work from that. And then Guillain-Barré is more of a, I think, from an acute condition when her first presented 5 years ago. So by definition, it wouldn't be, there's no residual of Guillain-Barré after 5 years. But again, yeah, it could be transverse myelitis and a chronic inflammatory condition, peripheral nerve neurological condition. But yeah, we haven't done any assessment in terms of a Guillain-Barré or anything to do with the Guillain-Barré because it was 5 years ago. Okay,
and then just very quickly, what was the spinal level of the transverse myelitis and how did that affect your management?
So it's reported C4. The thing is, she was not paraplegic or anything. She's more. It was weird in that she had some sensation in her chest and a sensation intact in her tummy, but her hands and her legs were not really. She couldn't really feel pinprick, and it was and that's her condition, like chronic condition. So we didn't have a level per se to say that she has a level. Because she had an intact ladder and bowel function, and she was mobilizing with the clutches as well. So we didn't have a level before, but after induction with the top-up, it was up to T4 basically. That's what we documented.
Okay, thank you. Now pass to our chair, Amanda.
So it's now I'm very proud and pleased to be able to introduce Dr. Arvind Palanisamy. I'm going to tell you a bit about him because he's got a very impressive CV. He's currently Associate Professor in St. Louis in the US of A, and he started off at medical school in Tamil Nadu. He then worked in New Delhi. He managed to get an FRCA on the way, but and it hasn't. He then went off to the USA instead, where he worked in Boston and Harvard, and I think he's mainly been in the USA since then. He's obviously been very prominent in SOAP. I see that he's been winner of the best scientific paper 3 times in SOAP over a long period of time. And he's also been one of their keynote lecturers in 2013. So we're very pleased and very happy to have him here at the Yorkshire Society of Obstetric Anaesthetics. And I'm pleased to hand over to him to give us our talk. Thank you very much.
Thanks, Amanda, for that lovely introduction, and thanks especially to Dr. K. Robbins and Dr. Makani Purva for the invitation. So I'm just waiting for my PowerPoint presentation to pop up in the share screen option. So just to give a brief overview of the topic while I wait for this to load. The next 25 minutes or so, I just want to lay a broad framework for COVID-19 and pregnancy, especially, detailing the clinical presentation and the epidemiology, so that the next speaker, Dr. Honor, would be talking more about the clinical anesthetic management of COVID-19 patients in pregnancy. The way I've done this slide, let me see here. So I've just organized this talk into 4 broad themes. So one is, what is unique about COVID-19 in pregnancy? And 2 is, what does pregnancy, the physiological state of pregnancy, do to COVID-19 presentation? And then finally, we look at what COVID-19 does to pregnancy outcomes, and then kind of delve into the more controversial topics of vaccination for COVID-19 in pregnancy. So these are the 4 broad themes, and I'll have about 5 minutes at the end for Q&A. So to better understand COVID-19 and pregnancy, we need to know that the immunological state of pregnancy is very nuanced. So we have downregulation of cell-mediated immunity, but this is not uniform. For example, you'll have diminished proliferation of lymphocytes to soluble antigens, and maybe even a marginally upregulated humoral response. So the relative immunosuppression that's often described is not the true state of immunological adaptation during pregnancy, but it's more of an immunological indolence or laziness, which allows the pregnant woman to tolerate the antigenic fetus, but at the same time evade infections from pathogens. So just to make this very obvious, if you look at the overall upregulation and downregulation of the two immune systems during pregnancy, you can see that starting in the second trimester, you have a downregulation of both CD4 and CD8 T cells, along with natural killer cells and cytotoxic T cells. Whereas if you look at the monocytes and the polymorphonuclear cells, they upregulate over time. So what this does is, especially during the third trimester, pregnant women are increasingly susceptible to infections, especially influenza, malaria, hepatitis, and herpes simplex. So with that introduction in mind, we need to see how pregnant women respond to previous influenzas, especially the pandemic ones. So if you look at the overall clinical picture, back in 1957 was another influenza pandemic, which people don't talk about, but more than 3 million people died. And then we have the H1N1 pandemic from 2009. And obviously, we don't have data from the first two pandemics about the ICU admission. But if you look at the overall ICU admission rates for H1N1 influenza, it's about 6%. And about 6% of women end up needing mechanical ventilation. But what's the striking feature about this is that if you look at the mortality rates, almost 20% of pregnant women with H1N1 back in 1918, as well as in 1957, died. And if you look at the latest data from 2009, there's almost a 5-fold increased mortality in pregnant compared to non-pregnant women. But what about the performance of pregnant women in terms of clinical outcomes with other coronavirus infections? And we have two of those. So one was the initial prelude to what we have right now. It's the severe acute respiratory syndrome virus that broke out in Hong Kong in 2003. And then you have the Middle East respiratory syndrome that is the most proximate to this pandemic, which is in 2012. And if you look at the outcomes here, it's very striking. And if you look at the incidence of ICU admission among pregnant women, look at the previous two coronavirus pandemics, the SARS and the MERS, almost half of all pregnant women needed ICU admission. So that's pretty severe infections. But if you look at COVID-19, the overall ICU admission rates for pregnant women is about 10%, and about 5% of them need mechanical ventilation, compared to about 40% of patients with SARS and MERS. And again, if you look at the mortality rates, it's really high. Almost 1 out of every 4 women with either SARS or MERS died. But if you look at the overall COVID-19 mortality rates in pregnant women, it's about 1.2%, which is pretty similar to the non-pregnant population, maybe marginally increased. So obviously, COVID-19 is a very unique infection, especially for pregnant women. And one of the striking features is the high asymptomatic rate. For example, looking at the initial outbreak during March and April in New York, as well as all the rest of the Northeast of the United States, the overall asymptomatic rate was almost anywhere between 45 to 88%. So that is 88% of patients with infection didn't even know that they had infected with SARS-CoV-2. And the other interesting feature that came out in these early studies from China, from Italy, from England, as well as from the United States, was that the vast majority of these infections were really mild. Almost 90 to 95% of infections were mild. And the initial case series actually described no mortality in pregnant women. So this is in stark contrast to the previous coronavirus pandemics and to the previous influenza A pandemic. So that's what is very unique about SARS-CoV-2 infection in pregnant women. So when this happened, we were pretty interested in our own institution. And when we started rolling out universal screening, screening of both patients admitted to labor and delivery, as well as patients admitted for general surgical procedures, we wanted to see the overall rate of asymptomatic positive patients, comparing obstetric patients to non-obstetric patients. And what we found was highly remarkable. So what we found was that there's almost a 10-fold increase in asymptomatic infection rates in pregnant women admitted to labor and delivery compared to the general surgical population, especially the age and sex matched population. For example, if you exclude the men from the data from the surgical units, there's almost a 10-fold increase in asymptomatic infection rates in pregnant compared to non-pregnant populations. So obviously, this is something that's very unique. We rarely hear about asymptomatic infections in influenza A, for example. So this is something that I got interested in the lab, and I was more interested in the mechanisms of why this might be so. So just to kind of give a basic primer on what happens with SARS-CoV-2 infection, I think by now everyone's an expert, but I just wanted to talk about two mechanisms. One is the ACE2 receptor, which is the binding site for the spike protein of the coronavirus. And then you need a protease called TMPRSS2. And what that does is it lyses the spike and allows the coronavirus to bind to the cell and internalize. So only cells that co-express both ACE2 as well as TMPRSS2 are the cells that are susceptible to infection. And what was very interesting when I was looking at the data was that estradiol especially was known to decrease ACE2 expression. And TMPRSS2, which is an androgen-sensitive receptor. So I was wondering, okay, what happens in pregnancy? Maybe the anti-androgenic state, because you have a high estradiol and high progesterone levels during pregnancy, would that decrease the expression of these receptors in the respiratory epithelium? And I was working with the pregnant rat model at the time, and I thought, okay, this is a good question to immediately find answers to. And what I did in the lab was harvest the nasal epithelium from term pregnant rats and compare them to age-matched female rats. And what I found was that the expression of both ACE2 as well as TMPRSS2, both the gene as well as the protein, was markedly reduced in the pregnant nasal epithelium. So here in these figures, the gray column is the non-pregnant rat and the pink column is the pregnant rat. And you can see that the expression of both ACE2, both the gene as well as the protein on the Western blots were decreased. We also performed ACE2 activity assays. And again, there was almost a 50% decrease in ACE2 activity in the pregnant nasal epithelium. So we kind of figured out at least one mechanism by which pregnant women may be able to resist COVID-19 or at least be asymptomatic. Obviously, here we show some data that the entry factors for SARS-CoV-2 may be reduced in the pregnant nasal epithelium. But what about severe COVID-19 in pregnancy? Because there's always this conflicting data. Pregnant women are more susceptible to ICU admission and mechanical ventilation. It turns out that despite the fact that a large majority of pregnant women are asymptomatic, once pregnant women become symptomatic, then the incidence of complications increases 3 to 5-fold. So this is one of the largest data sets from the Center for Disease Control in the United States, comparing only the symptomatic cases. The symptomatic pregnant patients, almost 23,000 of them, with symptomatic age-matched non-pregnant population, we have almost 380,000 patients. And you can see that the incidence of ICU admission is about 3-fold higher if the pregnant woman has COVID-19 and is symptomatic. And similarly, there's a 3-fold higher chance of invasive ventilation. But if you look at the death rates, again, mortality is not much different, even if a pregnant woman is symptomatic. But I must admit that in this particular data set, the pregnant women had a much higher rates of diabetes, hypertension, and preeclampsia. So I'm not entirely sure whether vast majority of this is driven by the COVID-19 itself or because of the comorbidities. So when you encounter such a scenario, I think we need to do a propensity matched analysis where you need to compare pregnant women with non-pregnant women with COVID-19 and see whether they are matched for their disease state. And this study from France and Belgium did exactly that. And what they found was that in this propensity matched analysis, where patients were matched for all the covariates that you can think of, including BMI, including hypertension and diabetes, the overall risk for ICU admission in pregnant women was 5-fold higher, and the risk of intubation was 6-fold higher. Again, with the caveat that only if these patients were symptomatic. The most striking aspect of this study compared to the previous study, again, was that there were no mortalities reported with severe COVID-19 in pregnancy in this particular data set. So we, again, looked at this in our own institutional data set, and we compared symptomatic pregnant patients with COVID-19 with non-pregnant patients with COVID-19 who were symptomatic. And we classified the disease according to 2 different criteria. So the first one was the novel coronavirus epidemiology tool that came out early on in March from China. And then we also used the WHO ordinal scale for categorizing disease severity. And based on both of these measures, what we found was that the incidence of severe COVID-19 in pregnancy was almost 3.5-fold higher, or up to 6-fold higher, depending on which criteria you use. Similarly, the overall rate of ICU admission was 10-fold higher if it was a pregnant patient with COVID-19 compared to a non-pregnant, age-matched female patient with COVID-19. So I think broadly, at multiple levels, it's very obvious that if you have a symptomatic COVID-19 patient in pregnancy, she is likely to need ICU admission and mechanical ventilation. So we have looked at what pregnancy does to COVID-19. So it's important to know what COVID-19 does to pregnancy. And there are multiple studies out there, each with differing outcomes. So I think the best way to summarize that is by putting together this meta-analysis, which was done by Alate from the National Perinatal Epidemiology Group in Oxford, United Kingdom, which was published last year, involving about 192 studies with 64,000 pregnant women with COVID-19. And the comparison group was non-pregnant women with COVID-19. And you can see that the odds ratios for mortality, for ICU admission, for preterm birth, and for C-sections were much higher. And similarly, if you look at all the perinatal outcomes, like stillbirth, neonatal death, admission to the NICU, and fetal distress, were all much higher in pregnant patients with COVID-19. So one caveat with all of these studies is, most of the data comes from the first 6 months of the pandemic, when people did not know how to truly manage these patients. So there was a much higher incidence of C-sections. People did not want to take risks. People did not know how to handle, respiratory compromise in pregnancy. So I think we need to kind of wait for more data in the past 6 months or so to be able to make a better picture. So moving on to the next important question is about vertical transmission. So if you have a pregnant patient with SARS-CoV-2 infection, is it likely to cross the placenta? And this is a question that concerned everyone. So the data I'm showing here is single-cell RNA sequencing data from human placenta. You have these scatter plots with different cell types and these fancy colors. But I'd like you to focus on these green dots. And the green dots are the ACE2 gene expression in the villus cytotrophoblast and the decidual stromal cells in the placenta, suggesting that at least the human placenta has all these cellular mechanisms that could enable transmission of the virus across the placenta into the fetus. However, if you look at all the data from the first trimester, there are 2 good studies that were published late last year, looking at the impact of SARS-CoV-2 infection during the first trimester and whether it increases abortion rates or whether it has any impact on fetal development. And both of these studies showed that there was no overrepresentation of COVID-19 in a case-controlled study involving spontaneous abortions. So this study came out of Italy, and another study that came out of Denmark, they looked at the nuclear translucency thickness as a surrogate for fetal well-being after SARS-CoV-2 infection, and they found that there was no impact of SARS-CoV-2 infection on fetal development. And again, in none of these studies where there's any evidence for spontaneous miscarriage in SARS-CoV-2 positive women. So I think overall, the data from all of these studies are quite reassuring in that if you have SARS-CoV-2 infection during the first trimester, it's unlikely to lead to pregnancy loss or cause fetal maldevelopment. And what about vertical transmission at birth? This is, again, a big concern because this would have huge implications of how you handle the baby, whether you separate the baby from the mother or you home the baby with the mother. And again, there's a lot of data out there, but I would just want to share the latest meta-analysis, which shows that the overall transmission risk at birth from the mother to the baby is about 3%. It's actually very low. It's very reassuring. And this data comes out of numerous samples, including nasopharyngeal swab, placenta, cord blood, and multiple samples. And overall transmission risk appears to be about 3% from the mother to the baby at the time of birth. So moving on to the last topic, which is the immune response of pregnant women to COVID-19. So this is just a broad overview of what happens when you have SARS-CoV-2 infection. Preceding 1 week before symptom onset, you start showing an increase in the antibodies, especially a big jump in your IgG and IgM, as well as IgA, which is missing in the picture. And over time, they kind of decay. And by 6 weeks, a vast majority of the antibodies decay, except for the IgG ones. So what happens in pregnant women? This is a big question. And we know that because of all the immunological tolerance and adaptation in pregnancy, we're not entirely convinced that the pregnant woman would mount a good immune response against SARS-CoV-2 infection. I could not find much data in the literature, and the only paper I found was in medRxiv, comparing pregnant women with non-pregnant COVID-positive women in the reproductive age group. And this particular study looked at the antibody, the IgG antibody against the spike protein. And the first graph on the top, the red circles are the pregnant women samples, and the black circles are the non-pregnant women samples. And you can see that the overall production of antibodies against SARS-CoV-2 infection appears to be slightly lower in pregnant women compared to non-pregnant women. Again, a big point to note was that these patients were not matched for disease severity. So we're not entirely sure whether it's the pregnancy state per se that results in a poor immune response or whether it's due to differences in the severity of infection. But the most reassuring part of this study was the bottom graph, which is actually comparing the transfer of antibodies from the mother to the fetus. And you can see that there's a pretty good transfer of IgG antibodies from the mother to the serum, and the overall transfer ratio is about 0.9. So almost 90% of all antibodies in the mother seem to be transferred to the umbilical cord, suggesting that the baby may be protected from SARS-CoV-2 infection. So moving on to a more controversial topic, which is COVID-19 vaccination and pregnancy. So one of the earliest concerns when the pandemic broke out was that we didn't have developmental and reproductive toxicity data from preclinical models showing that mRNA vaccines are safe in pregnant rodents, especially rats and mice. And obviously, pregnant women were all excluded from the major vaccine trials early on. So we didn't have much data on postpartum and lactation periods. So early on, when this happened, both the CDC as well as the JCVI in the United Kingdom recommended vaccination only for the high-risk patients. But I know that the recommendation has recently changed in the United Kingdom. I think just about 2 weeks, maybe a week ago, where it's opened up to pregnant category as a high priority group. And similarly, a large number of institutions in the United States have recommended that all pregnant women should receive the vaccine and they should be prioritized. And the reason why these changes have happened are manifold, but we have some good data that's come out in the past month or so. So one of the first data points that we had was data from women who were not pregnant at the time of enrollment in all of these major trials with Pfizer, Moderna, and AstraZeneca, but then got pregnant during the course of the study. And again, in this particular population data set, there were no miscarriages in either the Pfizer or the Moderna group, and there's about a 17% miscarriage rate in the AstraZeneca group. The earliest concern at the time was that these mRNA vaccines could cross-react with a placental protein called syncytin-1 and cause miscarriages, but it's now been debunked through formal as well as natural experiments. We know that the overall miscarriage rate after vaccination is similar to the pre-pandemic times. And again, the mRNA platform, even though it's new for COVID-19 vaccination, the platform per se has been available for 15 years with pretty good safety data. And so far, we've had more than 20,000 pregnant women in the United States vaccinated with one of these mRNA vaccines, and there are no red flags. So I'm just going to share the latest information. In fact, this study was just published 2 days ago in the New England Journal of Medicine. So this is data from the Center for Disease Control in the United States. So they have an app system, called the VSafe, or the Vaccination Safe Surveillance System, for collecting data from pregnant patients. And this is patient-reported outcome data from over 4,000 pregnant patients who have received the mRNA vaccines. Unfortunately, we don't have data for the AstraZeneca vaccine, but the data from mRNA vaccines suggest that it's largely safe to use in pregnancy. So the interesting part of this study was that they were able to collate all the information about pregnancy loss, the overall incidence of spontaneous abortion, of stillbirth, as well as the neonatal outcomes such as preterm birth and neonatal death. And they were able to compare it with previously published data which they collated. And you can see that the overall rates are no different after mRNA vaccinations in pregnancy compared to the pre-pandemic incidences of any of these outcome measures. So overall, this particular study that just came out 2 days ago suggests that for the most part, mRNA vaccines appear to be safe in pregnancy. So the question is, are these vaccines effective in pregnancy? And that's a very valid question, because I've shown that the immune response with natural SARS-CoV-2 infection might be a little uptunded in pregnant women compared to non-pregnant women. So this particular study that received a lot of press, it came out of Harvard in the United States, looked at the immune response to either the Pfizer or the Moderna vaccine, and both of these vaccines were mRNA vaccines. And I apologize for this busy slide. So the top panel actually shows the antibody response, both in terms of the IgG and the IgA response. And the x-axis, you see V0, V1, and V2. So V0 is the baseline values for the antibodies, which was the time these patients received the first dose of the vaccine. V1 was the point where they received the second dose of the vaccine, and V2 was either 2 to 6 weeks after the second dose of vaccine or at the time of delivery. And you have both data from non-pregnant patients, from pregnant patients with just the infection but not vaccinated. So you can clearly see that with the vaccine, there's a big jump, even with the first dose of vaccine in terms of the generation of IgG antibodies. And what's surprising is if you look at the slide under panel F, the spike protein antibody titer, the antibody titers generated with the vaccines were far superior and far more numerous in quantity compared to natural infection, which is marked in yellow circles. So overall, this study was one of the most robust studies that came out about a month ago, showing that the vaccines actually generate a very good immune response in pregnant women, not just with IgG antibodies, but also with probably the more important IgA antibodies. So this is very reassuring data. And so this is probably one reason why both the JCVI as well as the CDC are now starting to recommend vaccinations in pregnant women. Another question that often comes up is, well, there is good immunogenicity of the vaccine in pregnant women, but does it cross into the breast milk, and does it cross the placenta? And the answer to both is yes. And again, it's data from the same study. And you can see that with even one dose of the vaccine, there's a pretty significant jump in the IgG antibody response, especially in the breast milk. And similarly, you would notice the same pattern with the IgA antibody under panel A. And if you look at the bottom panel, which is transfer of the antibodies into the cord blood, again, there's a pretty significant transplacental transfer of the IgG antibody. Obviously, the IgM, which is big, cannot cross the placenta, and is usually used as a marker for neonatal infection. So just all the data that I've shared so far seem to suggest that, at least for mRNA vaccines, they appear to be safe and they appear to be effective in pregnancy. So with that, I just want to conclude my talk by summarizing what's unique about COVID-19 in pregnancy. We have a very high asymptomatic infection rate. There is an increased risk of complications related to ICU admission and mechanical ventilation if the patient is symptomatic. But the mortality seems to be no different from age-matched populations, which I think is the single most striking feature compared to previous pandemics in pregnant women. So what does pregnancy do to COVID-19? Well, I showed some data suggesting that the state of pregnancy decreases the expression of ACE2 and TMPRSS2 factors in the respiratory epithelium. And the data that I didn't show was, also suggested, from my paper, suggesting that there's probably increased innate immune defense in pregnancy, which lends itself to the possibility of a unique host-pathogen interaction. And what does COVID-19 do to pregnancy? And we talked about an increase in preterm birth, an increase in C-section, but there was no increase in the incidence of miscarriages or spontaneous abortions. Again, the whole question about increased C-section is doubtful, because most of the data is driven from the first 6 months of the pandemic, where people did panic and did section a lot of women who really did not need to have a C-section. So I think we need to wait for more data, more robust data to come through. And finally, we talked about the special circumstances. I talked about how the immune response to just the natural infection is not as robust in pregnant women. But when you vaccinate them, they show a pretty good response. And in fact, the immune response with vaccination is actually much superior to the natural antibody response to SARS-CoV-2 infection in pregnancy. And I also presented some data on the safety as well as the efficacy of mRNA vaccines. So with this, I'd like to stop my talk, and I'll be happy to take some questions.
Thank you very much, Arvind. And as you can imagine, lots of questions are coming through on this very topical and new subject that has held our attention for the past year and a bit. So the first question I have is there any information on women who have been in ICU antenatally and then have long COVID and then need to deliver several months after?
Well, this is a fantastic question. And unfortunately, we don't have good data on the incidence of long COVID in pregnant women. I think this is an area that's ripe for investigation. My gut feeling, just based on what I'm observing in the lab, as well as the overall immune response to pregnant women with SARS-CoV-2 infection, is that the overall incidence of long COVID might be lower in pregnant compared to non-pregnant population. But that's just a hypothesis, which I think needs to be studied extensively, preferably with a large database.
Thank you. Our second question is there a higher incidence of renal injury compared to the non-pregnant patients?
Oh, that's a really good question. To my knowledge, the main data set that I go to is the paper by the perinatal epidemiology group from Oxford, and they did not seem to show an increase in renal injury. The incidence of ICU admission and mechanical ventilation was higher, but that's a great question. I'm not aware of any good high quality data suggesting that that's the case.
Okay. And then another question just regarding the science of how the virus gets into the cell during pregnancy, and how during pregnancy it's modulated and it's reduced. Using this mechanism, would it be possible to modulate this for non-pregnant patients to help prevent infection, use it as a prevention rather than a therapy?
Yeah, absolutely. In fact, the main motivation for me to study this in the lab was, I saw a lot of clinical trials using estradiol and progesterone supplements, to decrease the expression of these receptors. Unfortunately, none of these studies have been published yet. So I'm actually eagerly looking forward to that data. And I see at least 2 studies that have been registered in clinicaltrials.gov using progesterone and estradiol supplements in both women as well as men to decrease the incidence of SARS-CoV-2 infection.
Interesting. So watch this space. Another question is just in order to receive the benefit to the baby from breastfeeding with a vaccinated mum, would both jabs need to be received by 24 weeks gestation? Would that be the aim?
So that's a very good question. I think the data is still not clear. The cohort that I shared with you, the study showing transfer into the breast milk, this was based out of a sample size of 80 patients. So it's really hard to know whether it would transfer into the breast milk. But if you look at the overall transfer, it seems like the longer you wait, the more the likelihood of at least the IgG antibodies transferring into the breast milk. The data for IgA is much, this is only based on 10 patients, so it's really hard to come to that conclusion. But it looks very promising, and I would be surprised if that's not the case.
And then a further question just about vaccines in pregnancy. It's been a bit controversial regarding blood clots in relation to certain vaccines, whether some of that is political in Europe, I'm not sure. But I would have expected pregnant women to perhaps be more prone to blood clots. And is there any evidence? I know you said there was no red flags in the
yeah, that's a really, really good question, Kay. And I'm actually surprised to see that there's no concerning incidence of thrombosis in pregnant patients receiving the vaccine. That's very surprising to me. And the other surprising fact that even with COVID-19 in pregnancy, early on, we had this impression that pretty much every woman, because of the hypercoagulable state of pregnancy, need to be anticoagulated. And it was found that that was not found to be the case, and so we only anticoagulate really high-risk patients with COVID-19, especially symptomatic ones needing ICU level care, but otherwise we don't. And I think that probably is reflected in data from mRNA vaccines. That said, I don't know about good quality data from the AstraZeneca, which is often being cited as the more troublesome one for political reasons. So it'll be interesting to see if AstraZeneca is able to publish a series of reports from pregnant women. So I'm eagerly looking forward to that data.
Thank you very much, Arvind. That's all the questions. I'll pass you back to Amanda.
Yes, thank you very much. That was really interesting. Thank you. We're going to stick with COVID-19, but come a bit closer to home to Bradford, to someone I think we all know. I've certainly known Debbie for a while. So to Dr. Debbie Horner. She's a consultant in Bradford, and she's one of those people we're all really pleased to have, who, as well as being an obstetric anaesthetist, likes critical care. Imagine. And but apparently she does, and we do need those links, don't we? She seems to have been quite busy since I last saw her. She's now Deputy Operational Medical Director for the Trust, and she's also been working in Silver Command during COVID, which will put her in a very good position to tell us about it. So I'll just hand over to her. Thank you, Debbie.
Thank you very much, Amanda, and thank you for the opportunity to talk today. I'm going to be spending the next bit of time just talking about the sort of more clinical and shop floor aspects of managing COVID-19. So I have been very busy since we last met, and certainly since I last presented at YSOA, and a lot of my time over the last year has been mainly spent on ICU. But we have had quite a few pregnant women on our intensive care unit, and there's also been a lot of women with COVID-19 on our labour ward. So I suppose I'm sort of giving a kind of opinion from my own experience, but also what is out there in terms of the research. And there will be a little bit of overlap with Dr. Palanisami's talk, because I think the clinical aspects sort of go nicely with some of the more kind of lab-based things that he was talking about. So I'm going to talk about where we are with COVID now, what we've learned so far, how we manage these patients who are pregnant with COVID-19, and then my pet subject, which I can't do a presentation without, is where is the best place to care for these women, just a little bit at the end. So fortunately in the UK, we are in a lull at the moment, and it's twofold this. Actually, in the main, it's because of the lockdown, but obviously, we've had a very successful vaccine programme, which we're hoping will prevent any sort of significant further surges. We've already heard in the last talk about COVID vaccination in pregnancy, and that women in the UK are now going to be vaccinated as they would be by age, but also obviously comorbidity. Internationally, not such a great story. There's still a significant amount of COVID out there, and you'll all have seen the hideous pictures and stories from India, which just shows you how out of control it can get without lockdowns and without rapid rollout of vaccination. So I thought I'd show you this slide because it gives you an idea of where we might be in a couple of months' time. So this comes from a risk prediction model that we've been running in Bradford since the sort of early days of COVID. It's very specific for Bradford, but actually I think we're probably a bit like a canary in the mine shaft in terms of if it's like this in Bradford, it will probably be better than this in lots of other places, because we are particularly affected by issues around the risks of ethnicity, houses of multiple occupation, and deprivation and comorbidity. So with this model, we have predicted to the week actually when the peaks are going to have hit. And also we've got to within about 10 patients of the number of patients we have in our hospitals. So the axis upside is the number of patients in the hospital, then obviously time along the bottom. So you can see we had a sort of double wave in November and January, which I think a lot of people of you will be familiar with from your own units and across the region. The interesting bit is the sort of next surge. So I think the really positive thing is that it's likely to be much smaller than what we've seen before. The purple line in the middle is the most likely scenario, and this was designed just a few weeks ago, so on the 2nd of April. And then the kind of confidence intervals vary, how much uptake of vaccine we have within the population, and also how the government decides to release lockdown. So reassuring really that I think we've definitely seen the worst of it, and hopefully we're nearly there with the vaccine programme and shouldn't have to, fingers crossed, lockdown again. So I'm going to talk about what we've learned so far. Some of it obviously will overlap with the last talk, but hopefully with a sort of the clinical management side of it. These are the 4 main studies that I'm going to talk about, or 4 main publications. The one which is very useful if you're looking for something just to give you an update on the management of COVID is probably the one published by the College of Obs and Gynae. So it gives you how we should be managing these women. It's recently been updated and it's got a lot of references in there if you're interested to do any further reading. What I would say is things are moving fast even now with publications from a COVID perspective. So if I have missed anything that's just recently been published, I last looked last week, but if I have missed anything, then apologies for that. So I'm just going to mention the Living Review, which was mentioned in the last talk. It's actually just been updated. It's included 192 studies and a huge number of women. It is not just UK data, it's international. So there are going to be some differences from that, I think, compared to just the UK data. But the main findings, which we've already talked about, are that women being asymptomatic is a very significant thing. If women are symptomatic, then the most common presentations are with fever and cough. ICU admissions relatively low, and death very low at 0.02% in that review. In terms of the risk factors, they're very similar to those in non-pregnant patients. So age, BMI, diabetes, hypertension are all risk factors for severe COVID. But from a specifically maternity perspective, preeclampsia is also important. And then if you look at risk factors for serious complications, it's all the same as those above, but you can also add in non-white ethnicity there. We've already had a look at these comparisons with pregnant women without COVID, and there's an increased risk of death, ICU admission, preterm birth, and also neonatal admission. So the next study I'm going to talk about is the combined study by YSOA, UCOS, and Embrace. Now, you're probably all familiar with UCOS and Embrace, but YSOA might need a bit more explanation if you don't have an ICU interest. So it's an international severe acute respiratory and emerging infection consortium, which you see why they shortened it. But specifically the data that they've used in this study is UK data from 300 hospitals, and it's funded by UKRI and NIHR. And they included all cases of women that were pregnant and either had a positive COVID diagnosis on PCR or respiratory compromise with radiological change that was consistent with COVID. Again, 52% of women were asymptomatic. They highlighted that they thought that the apparent excess of hospitalizations in young women was probably due to admission screening. What they did notice was that symptomatic pregnant women receive treatments late or not at all, and more about that later. And they also recognised that it was possible that the amount of, or the likelihood of requiring respiratory support might have increased recently because of some of the newer variants, although that was just a hypothesis, it's not definite. They also noted that actually there was some indirect effects of COVID, and that there was an increasing tendency for women to delay attendance at hospital or conceal pregnancy, and that this probably had already been linked to an increase in maternal deaths. So these are some of the slides, the next couple of slides that are the ones that were published by that group. So I just thought it was worth looking at those in a little bit more detail. So the first thing then about the median gestation of admission for symptomatic pregnant women, it's sort of middle of third trimester. Asymptomatic women, they said, was a bit later. I think that is probably because actually most of those asymptomatic women are being picked up by screening when they come in to have their delivery care or around the time of delivery. Again, it picks up the same links to age, ethnicity, comorbidities, but they've also found a link with asthma. Interestingly, 42% of symptomatic women were admitted for the primary indication of COVID symptoms. So it's not in the symptomatic group that they're being just picked up, or that it's coming in for some other reason. It's the COVID that's bringing them in. Outcomes then. We've talked about this already, but in absolute terms, women admitted to hospital with symptomatic COVID weren't at increased risk of adverse outcome, but they have pointed out that this is because of a lower threshold for admission. So I don't think that this is actually saying the opposite of the previous talk, but it's just about how the data appears in this study. 18% of symptomatic pregnant women required respiratory support, 10% required critical care, and 0.6% died, so slightly higher than that living review study. Preterm birth, I think, is definitely a thing. One of the things that I don't think we've quite flushed out yet is whether actually they would have delivered early anyway, or whether this is because we are intervening to deliver earlier because of respiratory compromise in the mother. It does look as though the proportion of women and the preterm birth is increasing rather than decreasing with this later update of the study. And there's also an increase in the proportion of infants that are then admitted to neonatal unit. But similar to the previous study, this study's found that very few neonates actually had a confirmed postnatal infection. So the next study is the ICNOC data. So this is an intensive care national audit. It's been running for many years and collects data from all of the intensive care areas in England, Wales and Northern Ireland. They rapidly started collecting data about COVID as soon as the first wave started. So they have got a lot of data for COVID, but specifically from critical care. Although they do say that there have been some data that have also been contributed from surge in other areas. I think there's they've previously commented that they know that they're not collecting enough data on sick women that are cared for on labour ward, and I don't think that's changed with COVID particularly either. I thought this slide was quite interesting. There's quite a lot more women who have been admitted with COVID in the sort of latter phases of the pandemic. I wonder whether, I don't know whether this is a reflection of the fact that maybe women are more susceptible with the variants. I think that's unlikely. I'm not sure. But the other thing is, I do wonder whether women are getting exposed more, have been exposed more in the latter phases of the pandemic, because in the first wave, all the schools shut, and even the key worker children, there were very few going to school. And I do wonder whether part of this is exposure to coronavirus, rather than it actually being that they have become more susceptible to COVID. So this is the data. So this is UK data looking at admission, those women who are admitted to intensive care units. Again, it's picked up that if you are either Asian or Black, you're far more likely to be needing critical care admission, and deprivation is also linked to critical care admission. Interestingly, if you're just looking at UK data, actually there is a lower risk of you needing invasive ventilation within the first 24 hours. You're likely to need less oxygen if you're pregnant, and you've also got a better outcome, so less likely to die. So I think that in terms of outcome and mortality, I think that is consistent with other sort of international studies. But it's interesting that we seem to not be seeing that same those same kind of issues with invasive ventilation that have been seen in some of those international studies. And I do wonder whether there's something specific in there about us choosing to admit women to critical care at an earlier stage of illness. So perhaps we've got the less sick women on there, and that skews the data. Because actually, from a personal note, from the women that we've looked after, I have got the impression that for the sort of similar age, the women who are pregnant do appear to be disproportionately sick compared to sort of similar women that we've seen. So I don't know. I don't think it's clear. I think there's probably something in the way that we admit women. Yeah, it'd be interesting to see what happens with further data on this. So what I'm going to talk about next is some of the clinical management. Now, most of this has come from that RCOG document that I showed you at the beginning of the talk. And then I'll go on and talk a little bit about some of the trials and where this has come from. So in terms of VTE, the current UK guidance is that all inpatients who are pregnant with COVID should have prophylactic low molecular weight heparin, unless obviously you're expecting birth imminently or there's a significant risk of hemorrhage. From a severe COVID perspective, it's less clear. So we do know from studies that therapeutic anticoagulation of women, of any patients who are on ICU, is a bad idea, in particular, I think, if they are intubated, because there's a higher risk of hemorrhagic complications, and it doesn't improve outcome. It's a bit muddy when you're talking about ward level care, and it's even more muddy when you're talking about pregnant people. So I think it's definitely something to get the sort of MDT involved with. In our own unit, what we're doing is giving anyone who needs non-invasive ventilation BD prophylactic low molecular weight heparin, but having a very low threshold for starting treatment dose, especially in those who aren't intubated, until we can get investigations that will confirm that there isn't a DVT or PE, in which case we then step them down to the BD prophylactic dose. So on discharge, we do need to think about continuing that low molecular weight heparin for 10 days longer if there's persistent morbidity, and that would include immobility. And we mustn't forget those women who were admitted with COVID-19 in that immediate postpartum period. They should also get prophylactic low molecular weight heparin as the other groups, and also consider extending it if there's ongoing morbidity. Oxygen. So target for non-pregnant patients with COVID-19 is 88 to 92. RCOG's recommending a target of 94 to 98. I think this rationale is probably because of increased consumption in pregnancy and concerns about the baby. What I would say is that if you're struggling to maintain stats of 94 to 98, especially if you're starting to think about CPAP, then you really need to be starting to think about whether the woman needs to be delivered. Because one of the things that I've found with our patients, and I've heard others also talking about in some of the national groups, is that we sort of try and maintain the pregnancy as long as possible to allow fetal maturation. But you can get into a quite difficult situation with somebody who's on high amounts of oxygen and CPAP, then trying to facilitate delivery, and you can end up having to intubate someone to facilitate that, whereas if you'd done it just a little bit earlier, you might have avoided it. So CPAP is definitely something that we should be using in pregnant women. Follow up the hospital protocol. For us, our protocol for maternity is just to move the saturation target to that 94 to 98. Proning obviously becomes much more difficult as pregnancy progresses, but we have had quite a lot of success with having women either in a kind of semi-prone position or in the later stages of pregnancy, lateral, with regular position changes from side to side. Steroids. Basically, anyone who is needing oxygen and has COVID needs to go on steroids. It's the most successful treatment that we've got for COVID. And the RCOG suggested regimen is if the woman isn't about to deliver, you can give oral prednisolone or hydrocortisone for 10 days or until discharge, whichever is sooner. If delivery is imminent, then give IM dexamethasone, because that's going to help you with the fetal lung maturity as well. But then once you've given those 4 doses of dex, switch to oral prednisolone or IV hydrocortisone to complete a total of 10 days of steroid treatment. I'll come on to the sort of background to that in a minute, or how successful we are with that. Tocilizumab, I've only just about managed to get my tongue around that in terms of actually saying the word. So it does improve outcomes, including survival in hospitalised patients with hypoxia. Again, this is evidence mainly from non-pregnant patients. Data for use in pregnancy is limited, although there's no compelling evidence of teratogenicity or fetotoxicity. I still suggest you need to have an MDT discussion about the risks and benefits of giving it. The evidence isn't as compelling as the steroids, but it is still something that I think you should consider, especially if you have a particularly sick woman or someone who's deteriorating. Remdesivir, initially everyone got quite excited about. I think there's less convincing evidence now, and I've certainly seen less use in my own unit and less people nationally talking about it as a treatment for COVID. I think that given that the fetal risk profile is still unknown and there's caution with breastfeeding, it's probably not something that you would consider first line. And again, you'd want to have MDT involvement if you're thinking about giving it. So I'm just going to talk about a couple of the big trials that have been used to look at treatments in COVID. So the first one is Recovery. So that's a UK trial. It's got 39,000 participants in it. There's 181 sites across the UK that are actively recruiting to the Recovery trial. And essentially, you're eligible if you're an adult, you're hospitalised and you've got COVID. So that means that pregnant women are absolutely eligible to go into this study. And there's various different things that they're looking at, and they change over time. But the two which are currently open to pregnant women are monoclonal antibody cocktails and aspirin. The recovery trials already shown that there isn't any benefit of using azithromycin, convalescent plasma, hydroxychloroquine, and the antiviral drugs that are listed there. So I would really encourage you to just think about recovery trial and getting patients into it if you have women with COVID on your labour ward. I think one of the issues is that it's sort of out of sight, out of mind, and often the teams that are involved in recruiting to recovery are often based on the main site doing respiratory or critical care. So it might be that we need to be encouraging those specialties to come over and get involved if we have anyone with COVID, because actually they don't have to be very sick, they've just got to have COVID. The other trial is REMAP-CAP. So REMAP-CAP is an international trial with some forethought. It was specifically designed to be deployed in the event of an international pandemic, so very convenient. And it rapidly developed an element of it which was looking at COVID. Pregnant women can be enrolled into it, and it's already looked at things like steroids, antivirals, the interferons and interleukins, so like tocilizumab and saralimumab, convalescent plasma, and the full anticoagulation with heparin. It's still open to recruitment for high-dose vitamin C, simvastatin, aspirin, and angiotensin-converting enzyme inhibitors and ARBs. So at least a couple of those are fine for pregnant women. So again, REMAP-CAP, if it's being run in your hospital, and a lot of hospitals are contributing to this, please think about enrolling pregnant women so we can get a bit more information that's pregnancy specific. So I thought this was quite interesting and telling. So this is just looking at how we are treating pregnant women, again from the UCOS study that I mentioned earlier. So we're not giving the right treatment to women, even if they're critically unwell. And steroids is a prime example of that. So from the UCOS data, and this was updated recently, only 7% of symptomatic pregnant women were given steroids, and only 18% of the women who went to critical care were given steroids. So you'd have thought that it would be much higher than that. I think one of the issues, particularly around steroids, is confusion. So people sort of hear, well, there might be an issue with dexamethasone and giving it earlier in pregnancy and fetal brain maturation. And what ends up happening is people just don't give anything, rather than really kind of pushing that care for the specific protocol for pregnant women. And only 3% of symptomatic women who were pregnant were actually recruited into the recovery trial. So we really haven't moved forward with getting women into that study. Even after the results of dexamethasone from recovery trial, things haven't got much better. So it's still only 9% of women overall and 23% of those receiving critical care. So this is just summarising where women should be careful and what we need to consider from the RCOG guidance. So essentially, you need MDT involvement, and I'm probably teaching orthostochelics because you will have been looking after these women for the last year on your labour ward, but you obviously want to get senior input basically as soon as you've got someone in there who's got COVID and has oxygen and any signs of physiological distress. You also need to involve the women and the family, because quite often you end up with some difficult decisions to make around where that woman needs to be cared for and decisions about the best time and place for delivery. In terms of the most appropriate location for that care, we'll come on to it in a minute, but it's very specific to each organisation. I don't think there's a perfect answer. You just need to think about it for your particular unit. There needs to be an escalation plan in place, and one of the issues I think that I've seen in my own hospital is making sure that the specific concerns around the pregnancy and the baby are high enough in the minds of critical care team, and especially if women are on the respiratory wards or acute medicine wards, because they're not as used to looking after pregnant women and considering what the kind of impacts might be of what they're doing, and also the increased risk of preterm birth. For that reason, I think it's really important that there's daily consultant obs and gynae review, probably MDT review from the labour ward, because there's also quite a lot of the midwifery elements of care that I think get sort of glossed over when women are not on labour ward. And obviously, especially with visiting as it is now, it's really important to make sure that the family are kept updated with what the plan is. So ICU versus labour ward. Those of you that have heard me bang on about MIAC before, this is kind of exactly why we've been talking about making sure that we're delivering the right care for sick women wherever they are in hospital, and COVID is a prime example of that. So it is specific to every individual organisation. The things that I think everyone needs to think about is what's the skill set on your labour ward? Do you have critical care nurses who come there and look after sick women? If you do, you're very lucky. Do you have enhanced maternal care trained midwives? And what is the point at which that care tips into level 2 critical care and needing to transfer the woman over? I think there's probably been slightly more care for sick women at a higher level on labour ward, just because of how full ICUs are. And that's not just for COVID, but possibly even more so the non-COVID women, to keep them away from the COVID inpatients on the main ICU. The other thing I think that's important is how close is your labour ward to ICU. So if you send your ladies to ICU, but your labour ward and your neonatal support and your theatre is very close to your ICU, then it's relatively easy to implement a kind of rapid delivery if you need to, or obstetric intervention. If you're in a different building, that definitely needs more thought. And it's something that should already be there as a plan, but it's been highlighted by COVID that, you really need to have a robust plan for what happens if that baby suddenly makes an unexpected appearance while you're on a non-co-located ICU. The other thing is, of course, what's the risk to the other women on the labour ward if you keep your COVID ladies there, and how have you segregated it? And I'm more cautious about women being on our respiratory wards or RQ, because I do think they have much less exposure to pregnant or recently pregnant women than any ICU does, and the ICUs don't have a lot, but it's more than on the general wards. So I hope you all recognise these documents. So this is the recommendations and also the competency and training framework that we've produced in Yorkshire and Humber. And it's based on the national EMC document that was published in 2018. The main difference between these and the national document is the flexibility. So essentially you decide what you want to look after where in your hospital based on all of those factors that I had on the last slide. So it starts from the point at which you're worried about a woman deteriorating, and then you decide the point at which that enhanced care flips into level 2 critical care. And the last little bit of my talk is just a plea. So we have started collecting data on enhanced maternal care. So for those women who are sick but looked after on labour ward, and just so that for completeness, it also includes critical care data at the moment. We've got data sharing agreements now in place with every trust in Yorkshire and Humber, and I think all but a couple of units have actually actively started contributing data to this. And the remaining couple are on with it, so that's going to be imminent, and that's fantastic given that we launched the data portal in February this year. So I think I took this picture about a week ago. I think we're now approaching about 260 patients data. So if we want to kind of ever get to the point where we can get funding for enhanced maternal care, and also just to sort of look at what are the key themes and issues within each individual trust, because you can get your own data from the database. We absolutely need to collect this data so that we can inform kind of national funding and change around the enhanced maternal care and critical care for sick women. And it has already shown that COVID is part of it, with about 6.3% of the patients who are having enhanced maternal care or critical care are COVID positive. But it also shows that actually there's a lot of other stuff still going on. So it's about balancing that the COVID situation with business as usual, as you all know. So in summary, these women need to be assessed early. Be mindful of risk factors and rapid deterioration, because you can guarantee it'll happen out of hours if there isn't a detailed plan written. We need to consider oxygen and low molecular weight heparin. I didn't mention it earlier, but antibiotics aren't something we should be giving. And if you've started because you're not sure whether there's a bacterial element, then wind back as soon as you have got a bit more evidence that they're not required. Steroids if they're on oxygen, PRED if they're not delivering imminently, tocilizumab if they're on ICU, and possibly if they're on NIV outside of ICU. Early MDT involvement. Find out where's the best place in your unit and stick to it, and regularly review your plan and include outreach if you are uncertain or want a bit more critical care input. Remember the national trials, and please, please, please do engage with EMC and collect the data on these women and all of those other women who are still there. That's everything. Any questions?
Thank you, Debbie, for a very comprehensive talk. Just one of your messages there is about getting more involved with pregnant women into the studies. Can you just remind us at what point we would put a woman into the study? Does she need to be symptomatic? And if so, how symptomatic?
So it's it's women who are pregnant who have symptoms of COVID and a positive test, essentially. It's very straightforward. In terms of who to speak to, basically, as soon as you get somebody in who's pregnant with COVID, contact the recruiting teams, because they'll be able to go through the kind of the finer details of it. But different interventions are at different stages. So some of them are for NIV, some of them are for ward level care. So, and of course, they keep changing the different drugs which are being used depending on how many patients have been included in the study. So it's difficult to keep up to date with all of it. And the best thing to do is to contact the recruiting team. So there should be somebody available in your hospital if you're contributing to REMAP CAP or recovery.
Thank you for clarifying that. So another question is just regarding vaccines. Bearing in mind in the UK, we're just up to the age of 44 now. We're a little way away from our childbearing age. Should we take into account ethnicity and deprivation, giving them increased priority, bearing in mind they're more likely to be symptomatic, and more likely to have severe COVID, and more likely to die? Do you think we should prioritize on them in pregnancy?
Yeah, so very interesting question. Personally, I think yes, and it's not just in terms of pregnancy. I think in all groups, I think that's important. I think with the kind of non-pregnant group, I think we've probably missed the boat, because we do still see in Bradford actually some pretty poorly patients in their 40s without many comorbidities, but with deprivation and possibly mild comorbidities. But I think, personally, if it was up to me, I think that we should take into consideration those risk factors. I don't know whether it will happen just with the speed of the vaccine rollout, but if we had our time again, I think that's something that would have been helpful to look at.
Okay. So a question here about nasal high flow oxygen. Have you used this? Any experience with it?
Yeah, so we use nasal high flow quite a lot on the COVID ICU and in our kind of COVID ward areas. We tend to use it more as a something to intersperse with CPAP. So if in Bradford we've got a very low threshold for putting patients on CPAP, it's something that we've done from the outset on the back of some national and international trials looking at it and outcomes. So I wouldn't use it instead of CPAP, but I think it's a good adjuvant. And you often find that with nasal high flow, you probably get a little bit of PEEP with it, and it is better than delivering oxygen another way other than CPAP.
Okay. You mentioned from the Living Review that preeclampsia was a risk factor for severity. Is this due to pulmonary edema, or how does that work?
I don't know. I don't know what the sort of background is to that. I haven't actually looked at it myself. I suppose whether it's that sort of preeclampsia is a manifestation of hypertension in the future, or whether the sort of risk factors for preeclampsia are sort of similar to some of the risk factors for COVID, I'm not sure. I don't know whether Arvin's got an opinion on that. It was just something that I'd noticed, which I thought was quite interesting, that it had been picked up as a particularly maternity-specific issue.
Okay. Does anyone have any other questions before I pass back to Amanda? Okay, thank you, Debbie.
Thank you very much, everyone.